Markedly cyanosed, worsening when she cries. A CXR performed on day 1 is normal. Which of the following types of congenital cardiac anomaly is most likely? A. Patent ductus arteriosus. B. Epstein anomaly. C. Coarctation of the aorta. D. Tricuspid atresia. E. Tetralogy of Fallot. 32. Pick's disease affects which of the following? A. Frontoparietal lobe. B. Temporoparietal. C. Tetralogy of Phalate and Transposition of the Great Vessels. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011. Donnelly L.F., Pediatric Imaging, The Fundamentals. Philadelphia, PA, Saunders Elsevier, 2009. 32. C. Temporofrontal Pick's disease is a neurodegenerative disease, and one of the tauopathies, group of neurodegenerative diseases characterized by abnormal metabolism of tau proteins leading to. Chapter 14. Test paper 7, answers. 398. 398. Intracellular accumulation and formation of neurofibrillary tangles, similar to Alzheimer's disease, characterized by the accumulation of the PIC bodies. It is sometimes used synonymously with frontotemporal lobar degeneration, FTLD, although strictly it is incorrect since all causes of FTLD isn't pathologically PIC's disease. The primary imaging abnormality is that of cortical atrophy of the frontal and temporal lobes. These changes can be markedly asymmetric and affect one region much more than another. Volume of the head of the caudate nucleus may also be reduced. Differentials include Alzheimer's disease and corticobasal degeneration where parietal lobe involvement is more pronounced. Levine R. Frontotemporal dementia PIC's disease. In Define Dementia, Understanding and Preventing Alzheimer's and Related Disorders. Levine R. ed. Westport, C.T., Krieger Publishers, 2006:67. C. Temporofrontal D. Parieto-occipital E. Frontal. 33. A 36-year-old woman is being investigated for possible renal stones with CTKUB. An incidental polka dot appearance to the T12 vertebral body is noted on the axial CT images. MRI at the same level shows characteristic high signal in the vertebral body on T1 and T2W images. All of the following statements regarding this entity are true, except A. They may extend to involve the posterior element. B. They are commonly multiple. C. Compressive lesions are common in the lumbar spine. D. Low T1W lesions are more likely to be B. Active. E. Most are asymptomatic. (6778). 33. C. Compressive lesions are common in the lumbar spine. Vertebral hemangiomas are a Hemardima 2 lesion. Spinal hemangiomas are common and frequently multiple. The prevalence of hemangiomas seems to increase with age and is greatest after middle age, with a slight female predilection. Most hemangiomas are seen in the thoracic and lumbar spine. They are usually confined to the vertebral body, although they may occasionally extend into the posterior elements. Most spinal hemangiomas are asymptomatic. Occasionally, vertebral hemangiomas may increase in size and compress the spinal cord and nerve roots. Compressive vertebral hemangiomas can occur in patients of any age, with a peak prevalence in young adults and preferentially occur in the thoracic spine. CT shows the pattern as multiple dots, polka dot appearance. At scintigraphy, the appearance of osseous hemangiomas ranges from photopenia to a moderate increase in radiotracer uptake. The presence of high signal intensity on T1, W, and T2 weighted MR images is related to the amount of adipocytes or vessels and interstitial edema, respectively. Fatty vertebral hemangiomas, high on T1, weighted MR, may represent inactive forms of this lesion, whereas low signal intensity at T1, weighted MR imaging may indicate a more active lesion with the potential to compress the spinal cord. Rodalic MH, ETAL diagnostic imaging of solitary tumors of the spine, what to do and say. Radiographics. 2008, 28, for 10-1941. 34, D, decreased resistive index in hepatic 34. An alcoholic patient is referred for an ultrasound from the A&E department of your hospital. The request states that the patient has deranged liver function tests and raises the possibility of underlying liver cirrhosis. Which of the following findings would not help you to confirm this diagnosis? A. Caudate lobe hypertrophy. B. Increased echogenicity of the liver parenchyma. C. Coarse echotexture to the liver. D. Decreased resistive index in hepatic artery. E. Hepatofugal flow within the portal vein. Hepatic artery. There are many features of liver cirrhosis identifiable with ultrasound. Most commonly, these include an echo bright, irregular, shrunken liver, late stage, with a coarse echotexture and hypertrophy of the caudate lobe. Earlier in the disease, the entire liver can hypertrophy. Isoechoic regenerative nodules may be apparent. If measured, there should be an increase in the resistive index, RI, of the hepatic artery. Reversal of portal venous flow, hepatofugal, portalization of the hepatic veins, ascites and splenomegaly are extrahepatic signs that are commonly identified. Hepatocellular carcinoma is a major complication of cirrhosis that should always be borne in mind when examining these patients. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:7 1921. 35. D. In blunt chest trauma, the perforation. 35. A 53-year-old man is assessed by the receiving surgeon, having presented with severe chest pain, vomiting and sepsis. Mediastinal emphysema is evident on chest radiograph and. Chapter 13. Test paper 7, questions. 371. Computed tomography confirms esophageal perforation. Which of the following statements is incorrect with regard to this condition? A. Plain chest radiography is normal in approximately 10% of cases. B. Iatrogenic injury is the most common single cause of esophageal perforation. C. Upper esophageal perforations typically result in right-sided pleural collection. D. In blunt chest trauma, the perforation usually occurs in the lower third of the esophagus. E. Water-soluble contrast agents should be used for fluoroscopic assessment. Perforation usually occurs in the lower third of the esophagus. Esophageal perforation is a surgical emergency that carries a high mortality. Esophageal instrumentation, biopsy, balloon dilatation, and attempted intubation, iatrogenic, are the most common causes of rupture and typically result in lower esophageal injury. Spontaneous rupture, also known as Barr-Haff syndrome, arises when interluminal pressure is elevated during sudden and severe vomiting episodes. While esophageal rupture in blunt chest trauma is rare, this typically results in upper esophageal injury and resultant right-sided hydrothorax. Chapter 14. Test paper 7, answers. 399. Chest radiography signs include mediastinal and neck emphysema, mediastinal widening, and hydrothorax. Barium can be used in the assessment of patients with possible esophageal perforation, but only after water-soluble contrast swallow has not shown an abnormality. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:844. 36. D. Rheumatic fever. The imaging feature. A normally well 8-year-old child presents to the A&E department short of breath and pyrexia complaining of joint pain. Chest X-ray shows an enlarged heart with upper lobe venous blood diversion and small bilateral pleural effusions. No focal collapse/consolidation is evident, but there are patchy interstitial infiltrates in a perihilar distribution. Further questioning reveals that the child recently had a sore throat. What is the most likely underlying diagnosis? A. Toxic synovitis. B. Juvenile rheumatoid arthritis. C. Reiter's disease. D. Rheumatic fever. E. Septicemia. Features described are those of acute congestive heart failure. In the context of joint pain following a recent sore throat, and with no previous cardiac history, rheumatic fever should be considered. Rheumatic fever commonly causes a pancarditis with valve insufficiency that can lead to acute congestive heart failure in severe cases. This follows a streptococcal pharyngitis. Chronically, rheumatic heart disease can cause valve stenosis with varying degrees of regurgitation, arrhythmias, and ventricular dysfunction. Rheumatic fever as a child is the most common cause of valvular heart disease in adults in the Western world. The mitral valve is the most commonly affected. Currently, the disease rarely affects children in the West, but the condition remains common in the developing world. Chin TK, ETAL Pediatric Rheumatic Heart Disease. emedicine.medscape.com/article/891897 accessed on February 27, 2017. 37. Wilson's disease basal ganglia calcification. Common causes: hypoparathyroidism, pseudohypoparathyroidism, idiopathic, normal variant, physiologic with aging. Uncommon causes: AIDS encephalopathy. Septicemia. 37. All the following cause basal ganglia calcification except A. Pseudohypoparathyroidism, B. Lead poisoning, C. Aging, D. Hypothyroidism, E. Wilson's disease. 38. An 82-year-old woman presents with postmenopausal postmenopausal bleeding. Transvaginal ultrasound shows a thickened endometrium and a left adnexal lobulated multicystic lesion, which has some solid elements. Some of the cysts contain fluid levels and have thick septa. Which of the following is the most likely diagnosis? A. Endometriosis, B. Granulosa cell tumor, C. Endometrial hyperplasia and hemorrhagic corpus luteal cyst, D. Serous cyst adenocarcinoma, E. Fibrothecoma. 39. A 33-year-old woman with progressive atherosclerosis, birth anoxia, hypoxia, carbonic anhydrase 2 deficiency, carbon monoxide intoxication, Fahrenheit disease, ferrocalcinosis, familial idiopathic symmetrical basal ganglia calcification and microcephaly, Hall-Warden-Spatz disease, hemorrhage, hyperparathyroidism, hypothyroidism, cretinism, Kern-Sayer syndrome, lead encephalopathy, lipoid proteinosis, Mellis syndrome, methotrexate therapy for childhood leukemia, oculodentoosseous dysplasia, parasitic disease, e.g. toxoplasmosis, cysticercosis, Parkinsonism, phenylketonuria variants, pseudohypoparathyroidism, radiation therapy, Down syndrome, tuberous sclerosis, viral encephalitis. Reader millimeter gamut A49, basal ganglia calcification. Reader and Felson's gamut. Gamuts in Radiology, 2003, A. Skull and Brain. Page 40. Springer-Verlag, New York, Incorporated. Incorporated. 38. B. Granulosa cell tumor. Many ovarian tumors produce estrogen, the most common being granulosa cell tumor. This results in postmenopausal bleeding, irregular bleeding in premenopausal women, and precocious puberty in prepubertal girls. Breast tenderness is another sign, particularly in postmenopausal women. The fluid levels are caused by hemorrhage into the tumor cysts. Endometriosis tends to improve in postmenopausal women, as there is no longer estrogen being produced. It should not cause a thickened endometrium. Endometrial hyperplasia and hemorrhagic corpus luteal cyst are related to ovulation, so do not occur in postmenopausal women. Serous cyst adenocarcinomas may produce adnexal masses, but do not produce estrogen, so do not cause endometrial thickening. Fibrothecomas can produce estrogen and cause endometrial thickening, but tend to be solid hypoechoic lesions. Imeoka IETAL developing an MR imaging strategy for diagnosis of ovarian masses. Radiographics. 2006. 2004, 24, S147. Progressive increase in back pain and perineal pain was sent for further evaluation to the spinal surgeons. Axial and cornal reformatted CT image showed a well-defined lytic lesion of the right upper part of the sacrum with extension through the right sacroiliac joint and absence of a sclerotic rim. All the following are features of this lesion except A. Most commonly affected bone is sacrum. B. Extension into intervertebral disc helps to differentiate GCT from ABC. C. Septa show intense enhancement post-contrast injection. D. Donut sign on scintigraphy usually suggests an alternate diagnosis. E. Fluid level is not specific for this lesion. S14766. Weiss letter R, ETAL Primer of Diagnostic Imaging, 4th ed. Philadelphia, PA, Mosby Elsevier, 2007:1045. Chapter 14. Test Paper 7, Answers. 400. 39. C. Septa show intense enhancement post-contrast injection. Giant cell tumor of the spine occurs in the 2nd for th decades of life, more frequently in females. Sacrum is affected in 90% of such cases. It is usually located in the upper sacrum and sacral wing. Extension to the iliac wing through the sacroiliac joint is possible. Lumbar, thoracic and cervical spine may be affected. It usually predominates in the vertebral body, with frequent involvement of the posterior, arch extraosseous involvement of the soft tissues is common. Intervertebral disc invasion and extension into an adjacent vertebra are possible. In radiography, they appear as lytic lesion with cortical expansion. Expansion. CT demonstrates lack of a sclerotic rim. Bone scintigraphy shows increased radiotracer uptake. The tumor usually has low to intermediate signal intensity on T1 weighted MR images. Areas of high signal intensity suggest hemorrhage. More specifically, they have low to intermediate signal intensity on T2 weighted images, caused by hemosiderin and high collagen content. Enhancement reflects its vascular supply. Cystic areas, hemorrhage, fluid levels, and a peripheral low signal intensity pseudocapsule may also be seen. ABC occurs between 5 and 20 years but can manifest at any age. There may be a slight female predilection. Thoracic spine is most commonly affected. Spinal involvement is typically in the posterior elements, although extension into the vertebral body is common. Spinal ABC may extend into the adjacent vertebrae or intervertebral disc, ribs, and the paravertebral soft tissue. CT and MR. Imaging typically show a well-defined lesion with internal septation. Fluid level is better seen on MRI. The predominant bone scintigraphic pattern is moderate to intense radiotracer accumulation at the periphery with little activity at its center donut sign. Post-contrast images show intense enhancement of the septa. Solid components suggest secondary ABC. Rodalic MH, ETAL diagnostic imaging of solitary tumors of the spine. What to do and say. Radiographics. 2008, 28, for 10/1941. 40, D, adenomyosis. Adenomyosis can be focal or lesion. 40, a 38-year-old woman is undergoing investigations for infertility. She is otherwise asymptomatic. On hysterosalpingography, there is a large filling defect within the uterine fundus with a linear defect that extends into the filling defect. She subsequently has an MRI scan, which demonstrates a myometrial mass with indistinct margins, which abuts the junctional zone, and has lower signal on T2 when compared with the adjacent myometrium. There are a few focal high T2 signal intensity areas within, some which. Chapter 13. Test paper 7, questions. 372. Appear more linear. It demonstrates less enhancement than its adjacent myometrium. Which of the following is the most likely diagnosis? A. Leiomyosarcoma. B. Leiomyoma. C. Endometrial carcinoma. D. Adenomyosis. E. Hydatidiform mole. Diffuse, the latter being the more common. The etiology is unclear, but prominent endometrial glands extend into the myometrium with adjacent smooth muscle hyperplasia. Leiomyoma tends to be sharply demarcated as opposed to ill-defined and tends to have low-intensity T1 and T2 signals, although multiple signal characteristics are seen. It would be unusual for leiomyomas to have linear bands extending from the endometrium. This is more commonly seen in adenomyosis. Leiomyoma and leiomyosarcomas cannot be differentiated accurately on imaging. Secondary features of lymphadenopathy or metastasis can help raise the suspicion of leiomyosarcoma. Endometrial carcinoma usually presents in an older age group and tends to present with symptoms of irregular bleeding, which is why it is often diagnosed at an early stage. There would likely be endometrial thickening also. Hydatidiform moles would usually be identified clinically, particularly in a patient being investigated for infertility, as she would have raised beta-human chorionic gonadotrophin levels. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa. 41. Before being referred for a CT colonography, a patient asks to speak with a radiologist to clear up a few points regarding colon cancer. Of the following statements, which is most correct? A. Smaller polyps are more likely to be malignant than larger ones. B. Most colonic polyps are malignant. C. Gardner syndrome carries an increased risk of cancer but Peutz-Jeghers syndrome does not. D. Most colon cancers start as an adenomatous polyp. E. Inflammatory bowel disease carries. Pa. Lippincott, Williams and Wilkins, 2011:1046-7. Weissletter R. ETAL Primer of Diagnostic Imaging, 4th ed. Philadelphia, Pa. Mosby Elsevier, 2007:344. 41. D. Most colon cancers start as an adenomatous polyp. The vast majority of colon cancers begin as an adenomatous polyp, 90%, although the vast majority of polyps are benign, 90%. With increasing size comes an increased risk of malignant change. In addition, of the three recognized pathological subtypes, tubular, tubulovillous, and villous adenomas carry the greatest risk of malignant transformation. There are a large number of other risk factors for developing colon cancer, but among them are the hereditary polyposis syndromes. Peutz-Jeghers syndrome is less commonly related as the polyps are more likely in the small bowel, and the inflammatory bowel diseases Crohn's disease and ulcerative colitis. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa. Lippincott, Williams and Wilkins, 2011:812-13. Chapter 14. Test paper 7, answers. 401. 42. A. 30. Carries no increased risk of cancer. 42. A 75-year-old man presents with abdominal pain after eating and mesenteric angina is suspected. You decide to perform a celiac axis angiogram using a mechanical contrast pump. What is an appropriate volume and flow rate of contrast to use? A. 32 milliliters at 8 ml/SB, 20 milliliters at 20 ml/SC, 40 milliliters at 20 ml/SD, 30 milliliters at 20 ml/SE, 20 milliliters at 6 ml/S. 32 milliliters at 8 ml/S. The aim is to closely replicate the natural blood flow in the vessel. A hand-injected test run is essential before a pump run to highlight the anatomy and confirm that the catheter tip is not in a subintimal position. An 8:30 seconds injection delivers 8 ml of contrast per second to a total of 32 ml and lasts 4 s. The patients are usually asked to keep as still as possible and hold their breath to minimize artifact caused by motion. 43. B. Ovarian Brenner tumor. 43. A 62-year-old postmenopausal woman has a magnetic resonance imaging (MRI) scan to look for a hernia. In the right ovary is a 1 cm sharply demarcated low T1 and T2 signal solid mass with adjacent calcification. There is also a multilocular cystic lesion within the same ovary, containing multiple thin-walled septa. Which of the following is the most likely cause of the well-demarcated low-signal lesion? A. Ovarian fibroma. B. Ovarian Brenner tumor. C. Ovarian dermoid cyst. D. Endometrioma. E. Corpus luteal cyst. 44. Which of the following is specific? Tumors are uncommon tumors that are almost always benign. These tumors have a large fibrous component and therefore have a similar appearance to an ovarian fibroma, low signal on T1 and T2, weighted imaging on both ultrasound and MRI. Brenner tumors are commonly found with an adjacent epithelial tumor of the same ovary, usually mucinous cystadenoma. Hence, in this case, the diagnosis of Brenner tumor is more likely than ovarian fibroma. An ovarian dermoid would usually contain fat, but would also be in the differential diagnosis. However, the patient is postmenopausal, and so endometrioma and corpus luteal cyst are unlikely. Dannert W. Radiology Review Manual, 6th ed. Philadelphia, Pa. Lippincott, Williams and Wilkins, 2007:1048. Imeoka I. ETAL developing an specific for osteomalacia. A. Brown tumor. B. Looser zone. C. Cloaca. D. Cyclops lesion. E. Wimberger sign. Developing an MR imaging strategy for diagnosis of ovarian masses. Radiographics. 2006, 26:14-3148. 44. B. Looser zones. Looser zones are a highly specific radiographic feature of osteomalacia. They are sometimes referred to as pseudofractures and are focal linear areas of undermined rallus osteoid at sites of mechanical loading. They are often seen bilaterally as linear lucencies that run perpendicular to the bone cortex and do not involve the whole bone width. Common locations include the medial cortex of the femoral necks, the inferior scapula, and the ribs. These need to be differentiated from bisphosphonate fractures, which start at the lateral cortex of the proximal femur, are often bilateral, and are termed as atypical fractures in patients on bisphosphonate therapy. Brown tumors are lucid lesions seen in hyperparathyroidism. Cloacas are seen in established osteomyelitis. Wimberger sign refers to localized bilateral metaphyseal destruction of the medial proximal tibias. It is a pathognomonic sign for congenital syphilis. Wimberger's ring sign, sometimes also called just Wimberger sign to create confusion, is a radiographic sign seen in scurvy, showing thin pencil-like sclerosis along the epiphyseal margins. The Cyclops lesion is an intra-articular mass of fibrotic tissue that may be seen post-anterior cruciate ligament, ACL, graft repair. Jane T.P., Thorne M., atypical femoral fractures related to bisphosphonate therapy. Indian J. Radial imaging. 2012, 22, 317881. Monster B.J. E. Sign. 45. AP radiograph of the leg of a 3-year-old girl shows periosteal reaction in the midfibula. Exuberant periosteal reaction was worrisome for malignancy, and MRI was performed. Coronal stir images showed a low signal intensity fracture line surrounded by extensive soft tissue and bone marrow edema. No mass was depicted. Other sites commonly affected in toddlers' fracture include all the following except A. Tibia B, humerus C, talus D, calcaneum E, cuboid. Chapter 13. Test paper 7, questions. 373. 46. A 63-year-old man presents with progressive vertical gaze abnormality and ETAL. The requisites, MSK imaging, 3rd N. Philadelphia, Pa, Mosby, 2007. 367-9. 45. B. Humerus stress fractures of the lower extremities associated with the onset of ambulation are called toddler's fractures. These fractures typically occur in children between 9 months and 3 years of age, manifest with a refusal to bear weight, and are not preceded by recognized acute traumatic event. A similar injury can result from subtle torsional forces, such as those occurring in a toddler who stumbles and falls on a positioned foot. The typical toddler's fracture is a non-displaced oblique fracture of the distal portion of the tibia. Although other locations are less common, weight bearing can also account for toddler's fractures of the fibula, posterior aspect of the calcaneus, the base of the cuboid, and the talus. Jamie C. ETAL taking the stress out of evaluating stress injuries in children. Radiographics. 2012, 32, 25, 37, 55. Chapter 14. And cognitive symptoms. MRI of the brain demonstrates volume loss of the midbrain, which was described by the reporting radiologist as hummingbird sign. What is the diagnosis? A. Multisystem atrophy. B. Progressive supernuclear palsy. C. Parkinson's disease. D. Shy-Drager syndrome. E. Amyotrophic lateral sclerosis. 46. B. Progressive supernuclear palsy. Conventional MRI is usually not helpful in the diagnosis of early Parkinson's disease because it most often yields normal findings. In advanced disease, abnormalities of the substantia nigra, including volume loss, decreased T2 signal reflecting iron deposition, and blurring of the margins can be seen. However, the primary role of MRI is to exclude structural abnormalities that potentially mimic Parkinson's disease, e.g., NPH normal pressure hydrocephalus, intracranial mass, and bilateral subdural hematomas. FDG PET images are most often normal and show preserved metabolism in the putamen and globus pallidus. This is a defining feature of Parkinson's disease and allows differentiation from both PSP, progressive supernuclear palsy, and MSA, multisystem atrophy, Shy-Drager syndrome, which commonly demonstrate reduced basal ganglia FDG activity. In patients with MSA, Parkinson's type, abnormalities are confined to the putamen and include atrophy, symmetric hypointensity on T2 and T2 asterisk, weighted images, and slit-like marginal T2 hyperintensity. Putaminal atrophy appears to help discriminate MSA from Parkinson's disease, whereas T2 hypointensity is a nonspecific sign that can be seen in PSP, Wilson's disease, neurodegeneration with brain iron accumulation, and other acquired conditions. Patients with PSP exhibit atrophy of the midbrain and tegmentum, manifesting as third ventricular dilatation, reduced midbrain AP diameter or flattening of the superior midbrain. Reduced midbrain AP diameter at the level of the superior colliculi on axial images gives rise to the Mickey Mouse sign. Midbrain atrophy with relative preservation of pons produces the hummingbird sign or penguin sign. Additional findings include superior cerebellar peduncle atrophy and increased flare signal, both of which have reasonably high sensitivity and specificity in distinguishing PSP from Parkinson's disease and MSA. Browski SM, ETAL structural and functional imaging in Parkinsonian syndromes. Radiograph. (47) A patient is diagnosed with Helicobacter pylori infection. Which of the following findings would you not expect? A. Gastric ulcer. B. Duodenal ulcer. C. Linitis plastica. D. Polypoid gastritis. E. Thickened gastric folds. Radiographics. 2014, 34, 5, 12, 73, 92. 92. 47. C. Linitis plastica. Helicobacter pylori infects the gastric mucosa. In most cases, it is asymptomatic but can be associated with epigastric pain and dyspepsia. Imaging can demonstrate the sequelae of gastritis, thickened folds, polypoidal changes, and enlarged area gastricae, but most commonly patients have either a gastric or duodenal ulcer, or both. Helicobacter pylori is the most common cause of both gastric and duodenal ulcer diseases. Linitis plastica, also known as leather bottle stomach, is a form of gastric stenosis that leads to narrowing of the stomach, and which occurs secondarily to a number of conditions, but is most frequently seen secondary to malignancy. Dannert W., Radiology Review Manual, 7th N. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:8. Folds. 48. You performed a catheter angiogram and angioplasty for right popliteal stenosis on a patient in the vascular ward, and are there to review him the following day. The nurse asks you to prescribe him some analgesia because, overnight, his limb has become painful and pale with loss of power and intolerable tingling. Which of the following is your next step? A. Review the puncture site. You find no significant hematoma, and prescribe analgesics. B. Arrange for the patient to be taken back to the suite for further angiography. C. You immediately page the vascular surgeon on call. D. Organize urgent CTPA to exclude pulmonary embolism. E. You start the patient on low molecular weight heparin and organize US leg veins. (855). 48. C. You immediately page the vascular surgeon on call. You have just heard the dreaded symptoms and signs of compartment syndrome. The patient needs urgent surgical fasciotomy to prevent muscle necrosis. Any salvage treatment can be planned after that. Muscle edema will raise the intracompartmental pressure in the calf facial compartments. If it is not released promptly, it will lead to muscle necrosis. The patient must have suffered an embolus during the angioplasty procedure. This is a medical emergency and needs urgent treatment. The team can consider revascularization options after this is done. Kessel D., Robertson I., Interventional Radiology, A Survival Guide, 3rd N. London, Churchill Livingstone, 2010. Veins. 49. A 72-year-old poorly controlled diabetic gentleman with multiple foot ulcers undergoes an MRI examination to exclude osteomyelitis. All of the following are Mr. features of osteomyelitis of bones of the forefoot, except A. Low signal intensity in infected bone marrow on T1W images. B. Contrast enhancement of bone marrow. C. Decreased signal intensity of bone marrow on STIR images. D. Increased signal intensity of bone marrow on T2W images. E. Contrast enhancement of adjacent soft tissues. 2010. 49. C. Decreased signal intensity of bone marrow on STIR images. Osteomyelitis is the infection of bone of which the primary modes of pathogenesis are through hematogenous spread, direct spread through trauma, or iatrogenic source, and extension from. Chapter 14. Test paper 7. Answers. 403. Adjacent soft tissue infection. MR is highly sensitive in the diagnosis of osteomyelitis, of which the loss of the normal T1 weighted bone marrow fat signal is the most sensitive finding. Other additional findings include increased T2 weighted and STIR signals from the edema and inflammation. Post-contrast studies may reveal a rim-enhancing interosseous abscess, which would warrant surgical intervention. Dannert. Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott, Williams & Wilkins, 2007:137-8. 50. D. Rhombencephalosynapsis Dandy Walker. Tissues. 50. A malformation is defined as a congenital morphologic anomaly of a single organ or body part due to an alteration of the primary developmental program caused by a genetic defect. All of the following are examples of posterior fossa cystic malformation, except A. Blake's pouch cyst. B. Dandy Walker malformation. C. Arachnoid cyst. D. Rhombencephalosynapsis. E. Giant cisterna magna. Walker malformation is characterized by hypoplasia, or agenesis of cerebellar vermis, and cystic dilatation of the fourth ventricle, which can result in enlargement of the posterior fossa. Blake's pouch cyst is a result of absence of communication between the fourth ventricle and the subarachnoid space, leading to tetraventricular hydrocephalus. The cerebellum has a normal size and shape. Typical neuroimaging findings include the presence of a cyst in a retro/infracerebellar location, which is essentially a diverticulum of the enlarged fourth ventricle. Giant cisterna magna is an enlarged cisterna magna, greater than or equal to 10 mm on mid-sagittal images, with an intact vermis, normal fourth ventricle, and in some patients, an enlarged posterior fossa. Consistent presence of hydrocephalus allows the differentiation of Blake's pouch cyst from megacisterna magna. Arachnoid cysts are well-defined CSF density extraaxial lesions in the posterior fossa, which do not communicate with the fourth ventricle or the subarachnoid space. They may enlarge during infancy and produce mass effect on the cerebellum and vermis, which may cause a secondary obstruction of the ventricular system, hydrocephalus and / or remodeling or thinning of the overlying occipital bone. Isolated hypoplasia of the inferior vermis with normal fourth ventricle has been described variably in literature as Dandy Walker variant. Rhombencephalosynapsis is characterized by the absence of the vermis and continuity of the cerebellar hemispheres, dentate nuclei, and superior cerebellar peduncles, which creates a horseshoe-shaped arch across the midline, resulting in a keyhole-shaped fourth ventricle. It is a key feature of Gomez-Lopez-Hernandez syndrome, parietal alopecia, trigeminal anesthesia, and craniofacial dysmorphic signs, and may be seen with Factral. Posterior cornal T2, T2 weighted images show the horizontal folial pattern. Bozeman T. Magna. 51. Which of the following combination of MRI signal is characteristic for cerebral abscess? DWI ADC. A. Low high B, high high C, high low D, low low E, isointense high. T. ETAL congenital abnormalities of the posterior fossa. Radiographics. 2015, 35, 1/220. 51. C. High-low. The typical appearance of a brain abscess at conventional MRI is that of a ring-enhancing lesion, with high signal intensity on T2, weighted images, and traumatic event. A similar injury can result from subtle torsional forces, such as those occurring in a toddler who stumbles and falls on a positioned foot. The typical toddler's fracture is a non-displaced oblique fracture of the distal portion of the tibia. Although other locations are less common, weight-bearing can isolated hypoplasia of the inferior vermis with normal fourth ventricle has been described variably in literature as Dandy Walker variant. Rhombencephalosynapsis is characterized by the absence of the vermis and continuity of the cerebellar hemispheres, dentate nuclei, and superior cerebellar peduncles, which creates a horseshoe-shaped arch across the midline, resulting in a keyhole-shaped fourth ventricle. It is a key feature of Gomez-Lopez-Hernandez syndrome, parietal alopecia, trigeminal anesthesia, and craniofacial dysmorphic signs, and may be seen with Factral. Posterior cornal T2 weighted images show the horizontal folial pattern. Bozeman T. ETAL congenital abnormalities of the posterior fossa. Radiographics. 2015, 35, 1/220. 51. C. High-low. The typical appearance of a brain abscess at conventional MRI is that of a ring-enhancing lesion, with high signal intensity on T2, weighted images, and low or intermediate signal intensity on T1, weighted images. A mature abscess has a low signal intensity capsule on T2, weighted images. However, the presence of a ring-enhancing lesion in the brain is not diagnostic of abscess, and must be distinguished from a necrotic neoplasm and other cystic lesions. Data from recent studies suggest that DWI is more sensitive than conventional MRI in distinguishing brain abscesses and cystic tumors. Pus in brain abscesses is strongly hyperintense on trace DWI and has a reduced ADC. On the contrary, most necrotic or cystic brain tumors have intermediate signal intensity on DWI and elevated ADC values. Carcinoma FW, ETA 52, a 37-year-old woman with a previous history of cervical carcinoma and radiotherapy presents with abdominal pain. On magnetic resonance imaging, there is a large cystic midline structure which has high T1 signal and some internal debris extending anteriorly and superiorly from the cervix. Coincidentally, in the cervical region, there is high/intermediate T2 signal surrounding the endocervical canal and disruption of the low-intensity cervical stromal ring. Which of the following is the most likely diagnosis? A. Cervical carcinoma recurrence causing hematometra. B. Cervical carcinoma with invasion of the uterus. C. Radiotherapy-induced cervical stenosis causing hematometra. D. Cervical carcinoma recurrence with metastasis to ovary. E. Imperforate hymen. 53. Which of the following statements is most AL diffusion-weighted imaging in the assessment of brain abscesses therapy. AJNR AMJ Neuroradiol. 2004, 25, 813-1017. 52a. Cervical carcinoma recurrence causing hematometra. Cervical carcinoma tends to be of higher signal on T2 than the surrounding cervical stroma, and in the above case, there is also disruption of the cervical stromal fibrous ring, increasing the likelihood of microscopic parametrial invasion. In this case, the cervical tumor is causing a malignant cervical stenosis and hematometra. High T1 signal is consistent with hemorrhage. Tumor is usually intermediate signal / hypointense, similar to myometrium on T1 imaging. Chapter 14. Test paper 7, answers. 404. After radiotherapy to the cervix, cervical stenosis with hematometra can occur. However, post-radiotherapy, the cervix becomes low signal because of fibrosis. Ovaries usually lie to either side of the midline, and it would be unusual for a cervical carcinoma metastasis of the ovary to have a high T1 signal. Imperforate hymen is congenital and is normally picked up either neonatally or at the time of menarche, if the metrical po. It would be inconsistent with a cervical cancer history, as this tumor is not seen in patients who are Virgo intacta. Dannert W., Radiology Review Manual, 7th ed. Ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:104950. Nicolay v. ETAL MR Imaging of Cervical Carcinoma, a Practical State. Most accurate regarding the use of endoscopic ultrasound. A. It is superior to cross-sectional imaging for local staging of esophageal cancer. B. It is superior to cross-sectional imaging in the assessment of liver metastases. C. It is less effective than cross-sectional imaging for local staging of rectal cancer. D. Staging approach. Radiographics. 2000, 20:15:39:49. 53a. It is superior to cross-sectional imaging for local staging of esophageal cancer. Endoscopic ultrasound, EUS, involves the addition of an ultrasound probe in the endoscopy apparatus. This has a number of clinical uses, which are currently being developed. Evidence already exists that EUS is superior to cross-sectional imaging in the local staging for assessment of both the primary tumor and local nodes of esophageal, pancreatic and rectal cancer. By visualizing the wall layers of the gastrointestinal tract, it is the modality of choice for assessment of submucosal lesions. EUS can be combined with interventional techniques, such as drainage, or fine needle aspiration cytology. It is useful for differentiating inflammatory and neoplastic pancreatic masses. Cross-sectional imaging remains superior in the assessment of liver metastases. Haas RH. The evolution of endoscopic ultrasound, improved imaging, higher accuracy for fine needle aspiration, and the reality of endoscopic ultrasound-guided interventions. www.medscape.com. View article /729124 accessed on February 28, 2007. D. It is less effective than traditional endoscopy for assessing submucosal masses. E. It is not useful in the assessment of a primary pancreatic mass. 54. You are called to perform a catheter angiogram on a 26-year-old biker who was involved in a road traffic accident. You are told that he has suffered a dislocated knee. The clinician informs you that his foot is perfused, but has sluggish capillary refill. He has a palpable dorsalis pedis pulse, but no posterior tibial pulse. Which of the following would you expect to find on the angiogram? A. Severed anterior tibial artery. B. Severed tibioperoneal trunk. C. Traumatic popliteal artery dissection. D. Atheromatous plaque at the peroneal origin. E. Normal anatomy. View article /729124 accessed on February 28, 2017. Of submucosal lesions. Ryan S., ETAL Anatomy for Diagnostic Imaging, 2nd ed. Philadelphia, Pa, Saunders, 2008. 55. E. Hemorrhagic ovarian cyst. Acute pelvic pain. Pain in adolescent girls is a common problem, but ultrasound scanning is very useful in differentiating the many possible causes. Anatomy. 55. A 13-year-old postpubescent girl presents to the emergency department with acute abdominal pain cited predominantly within the right iliac fossa. An ultrasound scan is performed. This reveals an echogenic mass within the right side of pelvis measuring approximately 4 centimeters. The sonographer thinks it is adjacent to and inseparable from the right ovary. What is the most likely diagnosis? A. Acute appendicitis. B. Ovarian dermoid. C. Ovarian torsion. D. Ectopic pregnancy. E. Hemorrhagic ovarian cyst. Causes. Hemorrhagic ovarian cysts are a common cause of pelvic pain in adolescent girls and appear as an echogenic mass in relation to the ovary. Acute appendicitis is likely to occur as a blind-ending tubular structure. This may appear like a target lesion in cross-section, and there may be fluid/collection adjacent to it. An acute appendix should be clearly distinct from the right ovary. Ovarian dermoids are usually predominantly fat-filled and therefore echogenic on ultrasound, but these tend to be a painless, incidental finding. Ovarian torsion can certainly produce an echogenic mass within the right pelvis, but this is less common than hemorrhagic cysts, and would not appear distinct from the ovary. Ectopic pregnancy usually appears as a donut-shaped complex mass in relation to one of the uterine tubes. A fetal heartbeat may be present. Donnelly, L.F., Pediatric Imaging, The Fundamentals. Philadelphia, Pa, Saunders, Elsevier, 2000. Cyst. 56. A young adult presented with complex partial seizures and amnesia. His MRI scan demonstrated T2 hyperintensity within the medial right temporal lobe, loss of hippocampal head digitations, and dilatation of the ipsilateral temporal horn of lateral ventricle. Which of the following is the most likely diagnosis? A. Herpes simplex encephalitis. B. Choroidal fissure cyst. C. Mesial temporal sclerosis. D. Early onset Alzheimer's disease. E. Post-seizure appearance. 2009. 2009. 56. C. Mesial temporal sclerosis. Mesial temporal sclerosis typically demonstrates an atrophic, T2 hyperintense hippocampus on imaging. Other pathology affecting the temporal lobe including infection and tumor would cause enlargement of the hippocampus. Alzheimer's dementia results in medial temporal atrophy, but T2, weighted hyperintensity is not a feature. Herpes encephalitis is caused by herpes simplex virus. Chapter 14. Test paper 7, answers. 405. HSV, type 1 in adults and HSV type 2 in children. It involves the limbic lobe, hypothalamus, parahippocampal gyrus, cingulate gyrus, and typically appears bilateral but asymmetric. Gyriform enhancement and hemorrhage are late features. Choroidal fissure cyst is a benign incidental finding, similar to arachnoid cysts in the brain. These occur in the region of the hippocampal fissure. Osborne A.G. Appearance. 57. A 32-year-old man presented to the A&E department after injuring his great toe. No fracture was demonstrated on plain X-ray performed, but incidental note was made of a flattened end. Chapter Informs you that his foot is perfused, but has sluggish capillary refill. He has a palpable dorsalis pedis pulse, but no posterior tibial pulse. Which of the performed? This post-seizure appear. Sclerotic metatarsal head with subchondral collapse compatible with chronic changes of avascular necrosis, AVN. Which metatarsal is the most common site of Freiberg disease? A. First B. Second C. Third D. Fourth E. Fifth. AG, ETAL Diagnostic Imaging, Brain, First N. Altena, A. Mirces, 2004. 57, B. Second Freiberg disease is essentially osteochondrosis of the metatarsal head, of which the second metatarsal is most commonly affected, and less commonly in the third and fourth metatarsal. 10% of cases are bilateral. MRI findings of subchondral fracture of the metatarsal head with severe marrow edema-like pattern suggest early-stage changes. Metatarsal head collapse with subchondral sclerosis and mild or absent marrow edema-like pattern suggests late-stage changes. Torian EM, ETAL MRI of metatarsal head subchondral fractures in patients with forefoot pain. AJR AMJ Röntgenal. 2008, 190. 35. Fifth. 58. A 39-year-old woman taking human menopausal gonadotrophins presents with pelvic pain, bloating and weight gain. On transvaginal ultrasound, both ovaries are enlarged and contain multiple bilateral cysts, some of which are 8 centimeters. There is also free fluid within the pouch of Douglas and surrounding the uterus. Which of the following is the most likely diagnosis? A. Large corpus luteal cysts. B. Endometriomas. C. Polycystic ovarian syndrome. D. Ovarian hyperstimulation syndrome. E. Ovarian torsion. (575). 58. D. Ovarian hyperstimulation syndrome. Human menopausal gonadotrophins are an infertility drug, which contains follicle-stimulating hormone and luteinizing hormone, derived from the urine of postmenopausal women and given as an injection. One of its main side effects is ovarian hyperstimulation syndrome, which can also occur because of high levels of beta-human chorionic gonadotrophin seen in multiple pregnancies and hydatidiform moles. Typical symptoms are those mentioned in the question, vomiting and nausea. Corpus luteal cysts are singular and usually unilateral. Ovarian torsion is more common in infertility treatment, but is usually unilateral, with ovarioedema 2 ovary containing small, subcentimeter cysts arranged around its periphery. Polycystic ovarian syndrome causes bilaterally increased ovarian volume, but cysts are usually small and subcentimetra. Endometriomas usually contain low-level echoes. Kornfeld D. Scout L. Torsion of a hyperstimulated ovary during pregnancy, a potentially difficult diagnosis. Emergency radiology. 2007, 14, 331. 331-5. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:10. 59. You are asked to perform an ultrasound scan on an asymptomatic 30-year-old pregnant woman for weeks, after the obstetrician incidentally notes a 3 cm hyperechoic lesion in the right lobe of the liver. On today's scan, you notice a 7 cm hyperechoic lesion involving segments 6 and 7 of the liver and subcapsular fluid. What is the most likely diagnosis for this lesion? A. Focal nodular hyperplasia. B. Liver hemangioma. C. Metastasis. D. Hepatic adenoma. E. Hepatic abscess. (1074), Grafe M. ETAL torsion of the ovary, sonographic features. AJR AMJ Röntgenal. 1984, 143:1331-4. 59. D. Hepatic adenoma. Hepatic adenomas are benign encapsulated liver lesions, which are usually 8-15 cm in diameter but can grow up to 30 centimeters. They are associated with the oral contraceptive pill, and can often increase in size during pregnancy. They appear as hyperechoic lesions on ultrasound, and are usually of low density on plain computed tomography, and enhance in the arterial phase with rapid washout. They have a risk of hemorrhage and, if rupture occurs, can develop into a subcapsular hematoma. Focal nodular hyperplasia, hemangiomas and metastases would not be expected to grow this fast. Hepatic abscesses can grow quickly, but the patient would be unwell, especially with spread into a subcapsular collection. Brandt W. Helm CA, Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia PA, Lippincott Williams and Wilkins, 2006:767. Abscess. 60, a 72-year-old man. Man presents with recurrent episodes of flash pulmonary edema. Magnetic resonance angiography shows bilateral renal artery stenosis with atherosclerotic disease at both renal artery ostia. Which of the following do you advise? A. No endovascular. Option B. Bilateral renal artery radiofrequency, RF, denervation. C. Bilateral renal artery angioplasty, and stenting. D. Continue with best medical management. E. Refer to vascular surgeons for bilateral renal artery endarterectomy. 61. A 7-year-old boy who is otherwise well is being investigated for chronic right-sided hip pain. (767-70). 60. C. Bilateral renal artery angioplasty and stenting. The results of the ASTRAL trial have shown no benefit of endovascular treatment when compared with best medical management of hypertension. However, recurrent flash pulmonary edema is a good indication for intervention. Surgical endarterectomy is a procedure that carries huge risks and has no role in this case. Radiofrequency, RF, denervation is a relatively new method. The renal arteries are catheterized via a common femoral artery approach. Using in Chapter 14. Test Paper 7, Answers. 406. RF generator. The artery is denervate, excluding the kidneys from the sympathetic control. The long-term results are unknown. The ASTRAL investigators. Revascularization versus medical therapy for renal artery stenosis. N. English J. Med, 2009. Pain. Which of the following diagnoses is most likely? A. Septic arthritis. B. Pertus disease. C. Slipped upper femoral epiphysis. D. Juvenile rheumatoid arthritis. E. Developmental dysplasia of the hip. (2009) 361:1953-62. 61. B. Pertus disease. There are a large number of potential causes for hip pain in children. However, many of the conditions have common presenting age ranges, which makes creation of a differential diagnosis difficult. Pertus disease is an idiopathic condition where avascular necrosis affects the femoral head, leading to chronic destruction of one or both heads of femur. It tends to affect boys between the ages of 5 and 8 years. Septic arthritis occurs at any age, but would not be expected to present as a chronic finding, especially as many children have associated septicemia. Slipped upper femoral epiphysis affects adolescent children, 12-15 years, and is usually associated with childhood obesity or in those who perform high-impact activity. Juvenile rheumatoid arthritis is similar to the adult form of the disease, in that it is idiopathic, but tends to affect the large joints of which the hip is not the most common. In addition, there are often other systemic features of the disease, as well as multiple joint involvement. Finally, this condition tends to present in younger children, 1-3 years. Developmental dysplasia of the hip presents in infancy, but if undetected will lead to chronic hip problems. Donnelly, L.F., Pediatric Imaging, The Fundamentals. Philadelphia, Pa, Saunders Elsevier, 2009. 62. E. Meningioma intramedullary. (62) Which one of the following is the incorrect association? A. Astrocytoma intramedullary. B. Abscess extradural. C. Nerve sheath tumor intradural extramedullary. D. Dermoid extradural. E. Meningioma intramedullary. 63. A 10-year-old girl of Jewish descent presents with pain in her left thigh. A radiograph. Intramedullary lesions of the spinal canal can be divided into 3 categories. Intramedullary lesions, ependymoma, astrocytoma, ganglioglioma, hemangioblastoma, PNET, metastasis, lymphoma, lipoma, epidermoid, abscess, vascular malformation, MS plagues, infarction, myelomalacia, sarcoidosis. Intradural extramedullary. Extramedullary, nerve sheath tumor, meningioma, lipoma, dermoid, metastasis from outside CNS, ependymoma of phylum terminale, arachnoid cyst, neuroenteric cyst. Extradural, dermoid, epidermoid, lipoma, lymphoma, metastasis, drop metastasis, meningioma, disc material, arachnoid cyst, infection. Dannert W. Radiograph revealed diffuse medullary osteoporosis, a flask-shaped distal femur, a serpentine area of sclerosis. Chapter 13. Test paper 7, questions. 376. Within the femoral metaphysis, and a sharply circumscribed endostele lytic lesion in the distal femur with a pathological fracture. Clinical examination reveals splenomegaly. Which of the following is the most likely diagnosis? A. Thalassemia. B. Osteopetrosis. C. Diaphyseal achlysis. D. Gaucher disease. E. Rickets. W. Radiology Review Manual, 5th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2003:186-7. 63. D. Gaucher disease. Although the Ashkenazi Jews are particularly predisposed to this hereditary condition, Gaucher disease is not confined to any particular ethnic group or sex. Splenic enlargement is detected in up to 95% of cases. There is abnormal modeling of the distal femur and proximal tibia secondary to marrow infiltration, leading to an Erlenmeyer flask deformity. This feature is, however, not diagnostic for Gaucher disease, and may be seen in all the other answer options. Diffuse medullary osteoporosis, bone infarcts, and sharply circumscribed endostele lytic lesions, owing to marrow replacement, can also be seen. The combination of Jewish ancestry, the radiographic features described, and splenomegaly makes Gaucher disease the most likely diagnosis. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011. Sutton D. Textbook of Radiology and Imaging, 7th ed. Edinburgh, Churchill Livingstone, 2003. Chapter 14. Test paper 7, answers. 407. 64. (64) A 29-year-old woman attends for a transvaginal ultrasound for dyspareunia. While passing the probe, you notice an anechoic cystic lesion in the lower vagina within the posterolateral wall. Which of the following is the most likely diagnosis? A. Lipoma. B. Nabothian cyst. C. Gartner duct cyst. D. Bartholin's cyst. E. Squamous cell carcinoma. 64. D. Bartholin's cyst. Bartholin's glands secrete mucus to lubricate the vagina, and are equivalent to the male Cooper glands adjacent to urethra, producing pre-ejaculate. They lie within the posterolateral portion of the lower vagina. Bartholin's cysts occur when the small duct becomes obstructed. Superadd infection can occur, leading to an abscess. Nabothian cysts are small mucus-filled cysts on the cervix and are very common. Gartner duct cysts are a Müllerian duct remnant and are uncommon. They have a typical location within the anterolateral proximal third of the vagina. Squamous cell carcinoma would usually appear as a thickened vaginal wall on ultrasound if seen at all. Usually, the proximity of the probe to the lesion can make it difficult to assess, so this is better demonstrated with magnetic resonance imaging. A lipoma would have the appearance of other superficial lipomas and characteristically would be hyperechoic. Dannert W. Radiology Review Manual, 6th ed. Philadelphia, PA. Carcinoma. 65. A previously healthy 36-year-old woman presents with acute hepatic failure of unknown cause. Her international normalized ratio, INR, is 2.6 and fails to normalize despite treatment. An ultrasound scan shows ascites. The liver team asks you to consider a liver biopsy. Which of the following is the most appropriate reply? A. Unable to perform because of INR and ascites. B. Advise the patient of the increased risk of bleeding and go ahead with liver biopsy. C. Drain the ascites and perform the biopsy. D. Perform transjugular liver biopsy. E. Perform transarterial liver biopsy. 66. (2007:1032), Siegelman E.S., ETAL high-resolution MR imaging of the vagina. Radiographics. 1997, 17:1183-203. 65. D. Perform transjugular liver biopsy. This is a commonly occurring scenario. Liver biopsy is contraindicated in the presence of ascites and coagulopathy. The transjugular approach is a good alternative where available. The right internal jugular vein is punctured and a catheter is advanced into a hepatic vein, usually the right. Through this, a long special specially designed biopsy needle is introduced and a biopsy is taken. The method is used for generalized liver disease and not for a focal lesion. An alternative method is the plugged liver biopsy. Here the biopsy is done over a sheath, and coils are dropped after the core is taken to plug the hole. Granger R.G., ETAL, EDS. Granger and Allison's Diagnostic Radiology. A textbook of medical imaging, 4th ed. London, Churchill Livingstone, 2. 66. A 79-year-old diabetic patient presents with right short-distance calf claudication. Magnetic resonance angiography shows focal stenosis of the right popliteal segment, and a decision is made to proceed to angiography and endovascular treatment. Which of the following is the best approach for catheter angiography? A. Right common femoral artery, CFA, retrograde B, left CFA, retrograde C. Right CFA, antegrade D. Right popliteal puncture under ultrasound scan E, left CFA, retrograde. 67. A 2 is taken to plug the hole. Granger RG, ETAL, EDS. Granger and Allison's Diagnostic Radiology. A textbook of medical imaging, 4th ed. London, Churchill Livingstone, 2001:1309. 66. C. Right CFA, antegrade the down the leg, antegrade, approach via right common femoral artery puncture is the easiest and most direct approach. Retrograde puncture is usually used for angiography and intervention at the iliac systems, aorta and aortic branches. Ultrasound scan is commonly used to visualize the vessels during puncture. The puncture can also be safely performed using anatomical landmarks and feeling for the femoral pulse. The CFA can be found in the midpoint between the anterior superior iliac spine and the symphysis pubis. By using USS, USS, the local anesthetic can be accurately placed around the vessel, ensuring good analgesia. The profundifemoris artery can also be visualized and hence minimize the chance of accidental puncture. The popliteal artery can be punctured using ultrasound guidance at the popliteal fossa, but it would not be preferred in this case. Kessel D. Robertson I. Interventional Radiology, a Survival Guide, 3rd ed. London, Churchill Livingstone, 2010. 67. A. Angular dermoid. The location of this lesion at the angle of the eyebrow with ultrasound imaging features such as contiguous. 2-year-old boy is referred for a painless lump in the right supraorbital region. The lesion is fluctuant on clinical examination. On ultrasound, it demonstrates low internal echoes and scalloping of underlying bone. What is the most likely diagnosis? A. Angular dermoid. B. Hemangioma. C. Neurofibroma. D. Lymphangioma. E. Aneurysmal bone cyst. 68. Which of the following is an absolute contraindication to vertebroplasty? A. Symptomatic vertebral hemangioma. B. Metastasis. C. Multiple contiguous bone scalloping, fluctuance and presence of mobile debris within the lesion is reassuring and points to a diagnosis of an angular dermoid. T1 hyperintensity demonstrated on MRI consistent with a fat 'Fat signal is diagnostic of this lesion. As the lesion may also contain debris, this may result in an inhomogeneous signal on MRI. A hemangioma would be expected to demonstrate flow voids and increased vascularity on ultrasound and MRI. The location is very unusual for a lymphangioma. Weiss letter R, ETAL Primer of Diagnostic Imaging, 5th ed. Philadelphia, Pa, Mosby Elsevier, 2011. Chapter 14. An elderly man presents to his GP with pain in his left middle finger in the region of the nail bed. This has worsened over the past 2 months. Plain film reveals a destructive lytic lesion within the distal phalanx of his left middle finger. What is the likely diagnosis? A. Breast cancer metastasis. B. Renal cancer metastasis. C. 68. D. Infection percutaneous cementoplasty, vertebroplasty, with acrylic cement, PMMA. PMMA, polymethylmethacrylate, is a procedure aimed at preventing vertebral body collapse and pain in patients with pathologic vertebral bodies. Indications: symptomatic vertebral angioma, painful vertebral body tumors and acetabular tumors, severe painful osteoporosis with loss of height and / or with compression fractures of vertebral bodies. Contraindications: hemorrhagic diathesis. Diathesis. Infection. Lesions with epidural extension. These require careful injection to prevent epidural overflow and spinal cord compression by the cement or displaced epidural tissue. The absolute contraindications are hemorrhagic diathesis and infection. Patients with more than 5 metastases or diffuse metastases are not candidates for vertebroplasty. Ganji A, ETAL percutaneous vertebroplasty, indications, technique, and results. Radiographics. 2003, 23, 2E10. C. Lung cancer metastasis. D. Gastric cancer metastasis. E. Pancreatic cancer metastasis. (69) C. Lung cancer metastasis. The most common sites for bone metastases are bones that contain red bone marrow. Hence, bone metastases have a predilection for the axial skeleton. Peripheral metastases are rare, and 50% of these are caused by lung cancer. The other options are also known causes of lytic metastases, but would be less likely to affect the hands. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008. 17. Metastasis. Metastasis. 70. A 34-year-old pregnant woman with severe abdominal pain attends for an MRI scan after an ultrasound showing a uterine mass. As well as the normal gestational sac, on T1W imaging there is a low signal mass noted within the posterior myometrial wall, which displaces the uterine cavity anteriorly. This mass has a high T1 signal intensity rim. On T2W images, this lesion is intermediate to low signal and has a low signal rim. Which of the following is the most likely diagnosis? A. Non-degenerated leiomyoma. B. Hyaline degeneration within a leiomyoma. C. Red degeneration within a leiomyoma. D. Myxoid degeneration within a leiomyoma. E. Cystic degeneration within a leiomyoma. 70. C. Red degeneration within a leiomyoma. Fibroids, leiomyomas, are benign tumors made of smooth muscle. Afro-Caribbean women are more prone than Caucasian women to developing fibroids. Fibroids can outgrow their blood supply and undergo degeneration, causing them to look very different on MRI depending on the type of degeneration that they undergo. Typically, a non-degenerated fibroid is a well-defined low-intensity lesion on T1 and T2 weighted images and enhances post-contrast injection. Hyaline degeneration is caused by necrotic central change and increasing collagen content. This causes variable signal on T1 weighted images but low signal on T2 weighted images. With calcific degeneration, the fibroid has similar signal characteristics on T1 and T2 to typical non-degenerative fibroids. Cystic degeneration can produce areas of fluid signal within the fibroid, which does not enhance. Myxoid degeneration results in a very high T2 signal with a little enhancement. Red degeneration is a very rare type of degeneration. It typically causes severe pain and can cause a fever. It is the result of thrombosis of the vessels surrounding the fibroid leading to the high T1 and low T2 signal rim, and it usually occurs in pregnancy. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott, Williams and Wilkins, 2011:1087-9. Murace E. ETAL uterine leiomyomas, histopathologic features, MR imaging findings, differential diagnosis and treatment. Radiographics. 1999, 19:1179-97. 71. E. Administer high-flow oxygen, and put the patient in the left lateral position. This scenario describes an iatrogenic. 71. You are performing a tunnel dual lumen dialysis line via a right jugular approach on a 50-year-old with chronic renal failure. As you are peeling the sheath, you hear a hushing sound and the patient suddenly becomes agitated, with an acute decrease in his partial oxygen saturation pressure. Which of the following is the most appropriate immediate management? A. Perform needle decompression in the right midclavicular line. Second interspace. B. Obtain a chest X-ray. C. Inject 10 ml of contrast down the sheath, and look for extravasation. D. Put the patient head down, and give fast intravenous crystalloid. E. Administer high-flow oxygen, and put the patient in the left lateral position. 72. The surgeons want you to review the CT of a young man. Iatrogenic air embolism. This is an uncommon complication that has an incidence of around 0.13%. Treatment includes high-flow oxygen and placing the patient. Chapter 14. Test paper 7, answers. 409. In the left decubitus position. This would allow the air to rise in the right atrium, where it can be aspirated using a transjugular approach. Needle decompression in the right midclavicular line is the treatment for attention pneumothorax. A chest X-ray might show air in the right heart, but will not help in the immediate management. Injecting 10 ml of contrast down the sheath is performed when you are suspecting extravasation, and placing the patient head down and giving fast intravenous crystalloid is the treatment for hypotension. Vesely trademark. Air embolism during insertion of central venous catheters. J. Vask Inter-Radiol. 2001, 12:1290. Man at an X-ray meeting. A young patient had been admitted with acute abdominal pain, and intussusception was diagnosed on pre-operative CT scan. Regarding this condition, which one of the following statements is incorrect? A. A lead point is rarely the underlying cause in adult cases. B. The intussusceptum is the entering limb of bowel. C. Ileocolic intussusception is the most common type in children. D. The CT appearance is of multiple concentric rings. E. Intussusception is the leading cause of acquired bowel obstruction in childhood. Extravasation and placing the patient head down and giving fast intravenous crystalloid is the treatment for hypotension. Vesely trademark. Air embolism during insertion of central venous catheters. J. Vask Inter-Radiol. 2001, 12:1291-5. 72. A. A lead point is rarely the underlying cause in adult cases. Intussusception refers to the telescope-like invagination or prolapse of an intestinal segment into the lumen of an adjacent loop. Approximately 95% of cases occur in children, usually affecting those under the age of 2 years. A lead point is an unusual finding in this age group, with mucosal edema and lymphoid hyperplasia secondary to viral gastroenteritis often being the underlying issue. Conversely, while intussusception in adults is uncommon, a lead point is far more commonly present. Lesions such as polyps, small bowel tumors, post-surgical changes and foreign bodies are recognized precipitants. In children, reduction of intussusception using either water or air can be attempted, provided that there is no initial evidence of perforation. A rule of threes is well known, whereby a maximum of 3 attempts at reduction with 3 minutes separating each attempt and a hydrostatic pressure equivalent to an infusion bag 3 feet, 91.4 centimeters, above the patient is observed. Surgical intervention may be required if such techniques are unsuccessful. Dannert W. Radiology Childhood. 73. A 10-year-old girl of African origin presents with colicky right upper quadrant pain and deranged liver function tests. Ultrasound of the abdomen demonstrates acute calculus cholecystitis. What is the most likely diagnosis? A. Sickle cell anemia. B. Familial hypercholesterolemia. C. Inflammatory bowel disease. D. Childocoal cyst. E. Thalassemia minor. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams & Wilkins, 2011:861-2. 73. A. Sickle cell anemia gallstones are an uncommon occurrence in childhood irrespective of the symptomatology, and therefore should always raise the possibility of a background predisposing condition leading to their formation. In the African population, sickle cell anemia is the most likely diagnosis. One must also consider other conditions such as malabsorption, Crohn's disease, thalassemia major in patients of Mediterranean origin, total parenteral nutrition, TPN, cystic fibrosis and short gut syndrome. The radiologist is often the first to raise the possibility of a predisposing condition. Children are at risk of the same gallstone-related complications as adults, including severe acute pancreatitis, which may be life-threatening. Dannert W. Radiology Review Manual, 74. A 60-year-old non-smoker presents with a history of increasing headaches and loss of consciousness. An unenhanced CT of the brain is performed which demonstrates high. Chapter 13. Test paper. Attenuation lesions within the cerebellum. All of the following may appear hyperdense on non-contrast CT, except A. Bronchogenic metastases. B. Melanoma metastases. C. Renal cell metastases. D. Prostate metastases. E. Thyroid carcinoma metastases. Metastases. 75. On an AP skull. 7th ed. Philadelphia, Pa, Lippincott, Williams & Wilkins, 2011. 74. D. Prostate metastases. Brain metastases may be solitary or multiple. Some tumors including breast, renal cell, colon and thyroid cancers are more commonly solitary, while others such as lung cancer and melanoma tend to be multiple. Imaging characteristics of metastases may suggest an underlying pathologic diagnosis. Metastases that classically hemorrhage include melanoma, choriocarcinoma, renal cell carcinoma, and thyroid cancer. Lung metastases are also known to hemorrhage. In the absence of hemorrhage, metastases may be hypodense, isodense, or hyperdense compared with the brain. Acutely hemorrhagic metastases appear hyperdense to brain. Melanoma metastases tend to be hyperdense to brain on CT even in the absence of hemorrhage. Think KR, think JR, Imaging of brain metastases. SURG Neural INT 2013. Radiograph. There are fractures of the pterygoid plate, maxilla, and nasal septum. What is the best classification for this type of injury? A. LE4 difacial fracture. B. LE4 2C. 2013. 4 Supple4 S20919. 75. A. LE4 difacial fracture. All LE4 fractures involve the pterygoid plate. In addition, LE4 involves maxilla and nasal septum. LE4 2 involves nasal bones, frontal process of maxilla, maxillary sinus, medial end. Chapter 14. Test paper 7. Answers. 410. Inferior orbital wall. LE4 3, in addition to 2, involves lateral orbital wall and zygomatico-frontal suture. LE4 2 fracture is also called pyramidal fracture. Dannert W. Radiology Review Manual. C. LE4 3D, depressed skull fracture. E. Pyramidal fracture. 76. A 56-year-old woman with known pancreatic cancer is brought from home by ambulance with hematemesis and melena. After stabilization, she undergoes endoscopy, which reveals isolated gastric fundus varices with a normal esophagus. She also undergoes abdominal computed tomography, which shows echogenic material in one of the splanchnic veins, consistent with thrombosis. Which of the splanchnic veins is most likely to be associated with isolated gastric fundus varices rather than gastroesophageal varices? A. Superior mesenteric vein. B. Inferior mesenteric vein. C. Portal vein. D. Splenic vein. E. Hepatic veins. Inferior orbital wall. LE4 3, in addition to 2, involves lateral orbital wall and zygomatico-frontal suture. LE4 2 fracture is also called pyramidal fracture. Dannert W. Radiology Review Manual, 6th ed. Philadelphia, Pa, Lippincott, Williams & Wilkins, 2007:208. 76. D. Splenic vein. The splanchnic circulation includes the superior mesenteric vein, inferior mesenteric vein, and splenic and portal veins. Hepatic veins do not form part of the splanchnic circulation, as they do not drain to the portal vein, but drain directly to the inferior vena cava, IVC. Chronic thrombosis of portal or superior and inferior mesenteric veins is often associated with gastroesophageal varices, owing to collateral circulation to IVC from submucosal veins of the esophagus. Isolated splenic vein thrombosis causes only gastric fundal varices, formed by short gastric vessels serving as collaterals. This is known as left-sided portal hypertension. Left-sided portal hypertension is often associated with pancreatitis or pancreatic cancer. Adam A. E. T. A. L. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:641. CORRC, Callaway M. Reethy 3_116, Liver, Vascular Disorders of the Liver and Splanchnic Circulation. London, The Royal College of Radiologists, 2010, Portal. Veins. 77. A 40-year-old with recurrent pulmonary emboli is due to have a hip replacement, and it is decided to deploy a temporary inferior vena cava, IVC, filter. What is the preferred site of deployment of an IVC filter? A. Suprarenal IVC. B. Infrarenal IVC. C. Proximal to the clot load, no matter the level. D. At the confluence of common iliac vessels. Portal.e-lfh.org.uk. 77. B. Infrarenal IVC. In the presence of normal anatomy, IVC filters should be placed inferior to the renal veins. This is to avoid potential clot propagation and renal vein thrombosis. If the patient has aberrant anatomy such as double IVC, a single suprarenal filter or twin IVC filters can be placed. Access is via right internal jugular puncture or a right femoral vein puncture. A cavogram is performed to visualize the renal veins and to look for aberrant anatomy as described above. Indications for IVC filter include deep vein thrombosis where anticoagulation is contraindicated, where the patient is non-compliant with medical treatment, or when there is free-floating thrombus in the IVC. Retrievable devices are available and should be removed within 14 days from insertion. Pulmonary embolism can still occur despite an IVC filter with an incidence of 2.7%. Brantwe, Helm C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Volume 3. Philadelphia, PA, Lippincott Williams and Wilkins, 2006. Iliac vessels E. At the junction of IVC and right atrium. 78. Which of the following is an appropriate puncture site for a percutaneous nephrostomy in a patient with normal sonographic anatomy? Anatomy. You anticipate no need for further intervention. A. Posterior calyx, middle/lower pole. B. Posterior calyx, upper pole. C. Direct puncture of the renal pelvis. D. Anterior, middle pole calyx. E. Anterior calyx, upper pole. (2006). 78. A. Posterior calyx, middle/lower pole. When further intervention such as antegrade stent placement or percutaneous nephrolithotomy is anticipated, a posterior upper pole calyx may be appropriate. Effort should be made to puncture below the 12th rib to avoid traversing the pleura. However, this is not always possible, and puncture between the 11th and 12th ribs can also be used with care. Direct puncture of the renal pelvis should be avoided as the adjacent vessels here are large. Anterior calyces should also be avoided, as puncturing these from a posterior approach increases the risk of renovascular injury because of the volume of renal parenchyma traversed. Brantwe, Helm C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2006:725. 79. C. Inguinal hernia. The child in this scenario has acute bowel obstruction, which can sometimes be missed on initial assessment. 79. An 18-month-old toddler with a history of premature depresence with an acutely distended abdomen and vomiting. He has not passed flatus for 24 hours. On examination, the referring accident and emergency registrar is concerned that the patient may have a torn testis, which he believes is causing the abdominal pain. An ultrasound demonstrates mixed echogenicity in the right scrotum. The testis could not be identified. What is the most likely diagnosis? A. Acute testicular torsion. B. Testicular carcinoma. Chapter 13. Test paper 7, questions. 379. C. Inguinal hernia. D. Femoral hernia. E. Sacrococcygeal teratoma. 80. A 31. Assessment. When assessing plain films, the hernial orifices should be remembered as an important review area, as inguinal hernia are common and should not be missed, both in children and adults alike. In this case, an ultrasound was performed first, but the same principles apply, and bowel loops in the scrotum are diagnostic. The radiologist may be the first to raise this possibility. Chapter 14. Test paper 7, answers. 411. An incarcerated hernia associated with obstruction or strangulation is an acute surgical emergency and requires urgent surgical intervention. Femoral hernia is uncommon in children. Acute testicular torsion may have a similar presentation and should always be considered. At least some part of a testis should be identifiable in case of torsion, tumor, or injury. Non-visualized testis strongly suggests hernia. Danner. 31-year-old presented with a 3-month history of progressive leg weakness, sensory disturbance, urinary hesitancy, urgency, and erectile dysfunction. He had treatment for sputum-positive pulmonary TB 1 year ago. MRI of the spine shows clumping of nerve roots within the thecal sac and empty thecal sac sign. Intradural cysts are also seen. What is the most likely diagnosis? A. Discitis. B. Cauda equina. C. Arachnoditis. D. Diastomatomyelia. E. Arachnoid cyst. Danner W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011. 80. C. Arachnoiditis. Infectious etiologies for arachnoiditis include bacterial, viral, fungal, and parasitic agents. Non-infectious etiologies include surgery, intrathecal hemorrhage, and the administration of intrathecal agents such as myelographic contrast media, anesthetics, and steroids. Neoplastic causes include metastasis from breast and lung carcinoma, melanoma, and non-Hodgkin lymphoma, or direct seeding of the CSF from primary CNS tumors like glioblastoma multiforme, GBM, medulloblastoma, ependymoma, and choroid plexus carcinoma. MRI is the most sensitive modality for diagnosis of arachnoiditis. Although arachnoiditis can be present throughout the subarachnoid space, it is most easily seen in the lumbar region where the cauda equina usually floats in ample CSF. In arachnoiditis, the nerve roots are regularly thickened and clumped together, often stuck to the dura, resulting in an empty thecal sac sign. Morisacco H. ETAL focal adhesive arachnoiditis of the spinal cord, imaging diagnosis and surgical resolution. J. Craniovertebral junction spine. 2010, 1-106. Ross J.S. ETAL. Cyst. 81, a healthy 12-year-old boy presents with painful ankles, no history of trauma. A plain radiograph of his ankles demonstrates bilateral symmetrical periosteal reaction of his tibia and fibula. His father reports similar symptoms in adolescence, but never had it investigated. No treatment is given. The boy had a further plain film performed after a football injury to his ankle at the age of 15 years. No periosteal reaction was seen at this time. Which of the following is the most likely diagnosis? A. Thyroid acropathy. B. Pachydermoperiostosis. C. Hypertrophic pulmonary osteoarthropathy. D. Hypervitaminosis. A. Venous insufficiency. AL MR imaging of lumbar arachnoiditis. AJR AMJ Rentgenol. 1987, 149, 510 25 32. 81. B. Pachydermoperiostosis. Pachydermoperiostosis is a self-limiting condition with similar radiological findings to those of hypertrophic osteoarthropathy, symmetrical bilateral periosteal reaction. It is seen in adolescence and is of autosomal dominant inheritance pattern. Males tend to be affected more often than females. Differential diagnoses of these radiological findings include thyroid acropathy, hypervitaminosis A, hypertrophic osteoarthropathy, metastases, and chronic venous insufficiency. All of the above require treatment before resolution of the periosteal reaction. Hypertrophic osteoarthropathy is caused by many pulmonary and non-pulmonary diseases such as benign and malignant thoracic tumors, chronic infection/inflammation, bronchiectasis, and lung abscesses, cyanotic congenital heart disease, inflammatory bowel disease, and liver cirrhosis. In HOA, resolution of the radiological findings is only really seen following treatment of the underlying condition. (82) A 40-year-old man presents with postprandial abdominal pain and 10 kilograms weight loss. A computed tomography scan with arterial phase imaging shows an indentation at the proximal celiac axis caused by the low insertion of the median arcuate ligament. Which of the following is the most appropriate treatment option? A. Catheter angiography and stenting. B. Open surgical management. C. Refer for laparoscopic division of the ligament. D. Catheter angiography and stenting. E. No indication. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa. Lippincott Williams and Wilkins, 2007:110. 82. C. Refer for laparoscopic division of the ligament. The symptoms and radiological findings are consistent with median arcuate ligament syndrome, the compression of the celiac axis by the median arcuate ligament of the diaphragm. The median arcuate ligament passes superior to superior to the celiac axis in 10% 24% of the population. It can cause hemodynamically significant compression in a small subgroup. Treatment is controversial, but benefit can be seen in cases where there is weight loss, post-stenotic dilatation along with postprandial pain. Laparoscopic ligation is the preferred method. Horton indication for treatment. 83. Which one of the following is not an indication for upper urinary tract drainage, nephrostomy, or stent, in the presence of renal failure and hydronephrosis? A. Retroperitoneal fibrosis. B. Mid-ureteric calculus. C. High-pressure chronic retention. D. Mid-ureteric stricture. E. Advanced pelvic malignancy. 80. KM, ETAL median arcuate ligament syndrome, evaluation with CT angiography. Radiographics. 2005, 25:1177 82. 83. C. High pressure chronic retention. Retention. High pressure chronic retention is a cause of bilateral hydronephrosis. It is usually caused by prostatic hypertrophy. The patient typically has a non-compliant bladder with incomplete emptying, although its overall capacity is often normal, or may even be below normal. The high pressure in the bladder causes functional obstruction of the upper tracts, and hence causes upper. Chapter 14. Test paper 7, answers. 412. Tract dilatation and impairment of renal function. Treatment is by catheterization, thus decompressing the bladder and upper tracts, and interval transurethral resection of the prostate if there is any recoverable bladder function. The other answers are valid indications for upper tract obstruction. Kessel D. Robertson I. Interventional Radiology. A Survival Guide, 3rd ed. Oxford, Churchill Livingstone, 2010. 84. A 65-year-old female patient with known disseminated renal cell cancer presence with increasing abdominal pain and distension. A computed tomography (CT) scan is performed which reveals moderate ascites and mild hepatomegaly. Portal venous phase images show geographic liver and hyperenhancement of a normal-sized caudate lobe. On delayed images, a characteristic flip-flop pattern of enhancement is observed. Which of the following is the most likely underlying diagnosis? A. Portal vein thrombosis. B. Acute Budd-Chiari syndrome. Chapter 13. Test paper 7. Questions. 380. C. Liver congestion secondary to fluid overload. D. Caliosis hepatis secondary to chemotherapy. E. Chronic Budd-Chiari syndrome. 2010. 84. B. Acute Budd-Chiari syndrome. Acute hepatic venous obstruction, Budd-Chiari syndrome, can be associated with disseminated malignancies. In addition to ascites and hepatomegaly, characteristic CT features are geographic liver, modeled liver enhancement, and a flip-flop pattern of enhancement, early phase hyperenhancement. Hyperenhancement of the central area of the liver with peripheral hypoenhancement, which reverses on delayed imaging with central hypoenhancement and peripheral hyperenhancement. The caudate lobe is spared as it has direct venous drainage to the inferior vena cava, bypassing hepatic veins. In the acute phase, the liver remains normal in size, but with chronic disease there is hypertrophy of the caudate lobe, which takes over the majority of liver function, thereby helping differentiation between acute and chronic Budd-Chiari syndrome. Peliosis hepatis may also be associated with disseminated malignancy, but CT demonstrates multiple spherical lesions with centripetal or centrifugal enhancement because of the presence of blood-filled cavities. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:7067. 85. C. Irregular liver contour syndrome. 85. A 47-year-old obese male patient with long-standing fatty liver infiltration and a strong family history of hepatic cirrhosis underwent liver biopsy, which confirmed the diagnosis of non-alcoholic steatohepatitis, NASH. He is to be followed up with imaging to exclude progression to cirrhosis. Which radiological feature is not typical for NASH? A. Low attenuation of the liver on computed tomography. B. High signal of liver on T1W magnetic resonance imaging. C. Irregular liver contour. D. Hepatomegaly. E. High echogenicity of the liver parenchyma on ultrasound. Non-alcoholic liver steatohepatitis is the second stage of non-alcoholic fatty liver disease, NAFLD, a very common liver disease that affects about 30% of the Western population. The most common cause for this disease is obesity and hypertriglyceridemia. The first stage of NAFLD hepatosteatosis is potentially reversible, but when untreated, 60% progress to NASH, which also has features of fibrosis and inflammation. Hepatosteatosis and NASH are indistinguishable radiologically, and NASH can only be diagnosed on biopsy, which is performed in high-risk patients. Progression to cirrhosis is observed in 10% of patients with NASH, where a small shrunken liver with irregular contour and secondary features of cirrhosis are observed. CORRC, Callaway M, Rethi 3_114, Liver, Cirrhosis and NASH. London, The Royal College of Radiologists, 2010, portal.e-lfh. Ultrasound. 86. A 70-year-old woman has a computed tomography scan for diverticulitis. An incidental 18 mm aneurysm in the midportion of the splenic artery is identified on the scan. Which of the following is the most appropriate treatment for this patient? A. Catheter angiography. B. Catheter angiography and coil embolization. C. Catheter angiography and stenting. D. Percutaneous thrombin injection. E. Conservative management and repeat. Portal.e-lfh.org.uk. 86. E. Conservative management and repeat scan in 6 months. Splenic aneurysms have an incidence of around 0.1% at autopsy. Indications for treatment include portal hypertension, size greater than 25 mm, female patient of childbearing age, and pseudoaneurysm. There is an increased risk of rupture in pregnancy. Interventional treatment is usually by coil embolization, although stent grafting and even transabdominal thrombin injection have been described. Madoff DC, ETAL splenic arterial interventions, anatomy, indications, technical considerations, and potential complications. Radiographics. 2005:25. Repeat scan in 6 months. 87. Which of the following is not a feature of holoprosencephaly? A. Single ventricle. B. Fused thalamy. C. Absent corpus callosum. D. Tectal beaking. E. Hypoplasia of the optic nerves. Supple 1, S191-11. 87. D. Tectal beaking holoprosencephaly. '88. A 69-year-old man with a chronic holoprosencephaly results from a lack of normal cleavage of the forebrain. The septum pellucidum is always absent in this condition. Holoprosencephaly may be divided into a lobar, semilobar, and lobar forms depending on the degree of abnormality. Tectal beaking is a feature of Chiari 2. Single ventricle, fused thalamy, absent corpus callosum, and hypoplasia of the optic nerves are all features of the various forms of holoprosencephaly. In its mildest form, lobar holoprosencephaly, absence of the septum pellucidum may be the only. Chapter 14. Test paper 7, answers. 413. Abnormality. The lobar form may be associated with septo-optic dysplasia, and the two conditions overlap. The degree of facial abnormality and mental retardation mirrors the severity of the intracranial abnormality. Donnelly LF, Pediatric Imaging, The Fundamentals. Philadelphia, PA, Saunders Elsevier, 2009. 88. C. Slow flow mimics sinus thrombosis on contrast-enhanced MRV. Chronic headache underwent an MRI brain and Mr. cerebral venogram, which showed a chronic thrombosis of the left transverse and sigmoid sinuses with evidence of recanalization. As far as diagnosis of cerebral venous sinus thrombosis is concerned, which of the following statement is false? A. Polycythemia can cause positive delta sign. B. Unenhanced MRI is more sensitive than unenhanced CT. C. Slow flow mimics sinus thrombosis on contrast-enhanced MRV. D. Turbulent flow is more of a pitfall on TOF MRV. E. Irregular sinus and intersinus channels suggest recanalization. MRV. The classic finding on unenhanced CT is a hyperattenuating thrombus in the occluded sinus, delta sign. However, this is seen in only 25% cases. Increased attenuation in the venous sinuses may also be seen in patients with dehydration, an elevated hematocrit level, or a subjacent subarachnoid or subdural hemorrhage. On contrast-enhanced CT/MRI, the empty delta sign is seen, a central interluminal filling defect that represents a thrombus surrounded by contrast-enhanced dural collateral venous channels and cavernous spaces within the dural envelope. Unenhanced MRI is more sensitive for the detection of venous thrombi than is unenhanced CT. The absence of a flow void and the presence of altered signal in the sinus is a primary finding. Slow or turbulent flow also may cause a signal intensity alteration in the sinus. The signal intensity of venous thrombi on T1 and T2 weighted MR images varies according to the interval between thrombus formation and the time of imaging. Time of flight, TOF, MR venography is the method most commonly used for diagnosis. Contrast-enhanced MRV utilizes the paramagnetic effect of intravenous gadolinium to shorten T1 relaxation time and provide positive intravascular contrast enhancement. Small vessel visualization is improved at contrast-enhanced MRV. Depiction of the dural sinuses is also superior with contrast-enhanced MR venography because of a decrease in the effects of turbulent/slow flow on vessel contrast. An irregular appearance of the sinus with multiple intrasinus channels and dural collateral vessels on MRV is characteristic of incomplete recanalization. Complete recanalization occurs more often in superior sagittal and straight sinus thrombosis than transverse and sigmoid sinuses after anticoagulation therapy. Leach JL, ETAL imaging of cerebral venous thrombosis, current techniques, spectrum of findings, and diagnostic pitfalls. Radiographics. 2006, 26, Sub 1 S 1941, Discussion S 42-3. 89, D. Recanalization. 89, which of the following statements is incorrect as regards the anatomy and imaging findings of the seminal vesicles and vas deferens? A. The seminal vesicles are located posterior to the bladder and distal ureters. B. Normal seminal vesicles appear hypointense and hyperintense on T1W imaging and T2W imaging respectively. C. The seminal vesicle joins the distal portion of the vas deferens, becoming the ejaculatory duct, and then drains into the prostatic urethra. D. The distal portions of the seminal vesicles and vas deferens are intraperitoneal. E. The seminal vesicles initially increase in volume with age, but then steadily reduce in size with advancing age. 90. A 6. D. The distal portions of the seminal vesicles and vas deferens are intraperitoneal. The seminal vesicles are paired, elongated septate structures that lie above the prostate and above the posterior wall of the bladder. Their fluid accounts for around 50%-80% of ejaculate. The seminal vesicle joins the distal vas deferens, forming the ejaculatory duct, which drains into the prostatic urethra at the vir montanum. The proximal portion of the vas deferens lies within the spermatic cord. The seminal vesicles and vasa deferentia are extraperitoneal structures. Seminal vesicle abnormalities are invariably found as incidental findings on imaging studies, although patients may present with hematospermia or infertility. Primary tumors of the seminal vesicle are very rare indeed, with the majority of neoplasia occurring from local spread of prostate, bladder, or rectal malignancies. Kim B. ETAL imaging of the seminal vesicle and (65-year-old smoker presents with an achy pain around both his ankles. The GP orders ankle radiographs to look for degenerative change. The report comes back describing smooth. Chapter 13. Test paper 7, questions. 381. Lamellar periosteal reaction with new bone formation in the distal dimetaphyses of both tibiae. Which of the following is the most likely cause? A. Systemic lupus erythematosus. B. Low-grade chronic osteomyelitis. C. Rheumatoid arthritis. D. Hypertrophic osteoarthropathy. E. Reiter syndrome. And vas deferens. Radiographics. 2009, 29:11:05:21. 90. D. Hypertrophic osteoarthropathy. Hypertrophic osteoarthropathy, or HOA, is characterized by smooth periosteal new bone formation, usually in the dimetaphysis of the long bones. The tibia, fibula, radius, and ulna are most commonly involved in 80% of cases, with patients usually describing painful, swollen joints. When present, caution must be given to look for an underlying thoracic cause, of which the most common etiology is bronchogenic carcinoma. In such instances, it is commonly referred to as hypertrophic pulmonary osteoarthropathy, or HPOA. Extrathoracic causes of HOA include inflammatory bowel disease and liver cirrhosis. Dannert W. Radiology Review Manual, 6th N. 91. E. Conservative management. Varicocele is a commonly identified correctable. You are performing a varicocele embolization. The patient suddenly develops left loin pain. He remains hemodynamically stable, but you notice contrast extravasation proximal to the coils. Which of the following is the most appropriate management? A. Inject polyvinyl alcohol, PVA, at the extravasation site. B. Stent grafting to exclude the extravasation site. C. Alert the surgical team, need to proceed to laparotomy. D. Take the patient for a computed tomography scan of the abdomen/pelvis. E. Conservative management. 92. Chest radiograph of a 12-year-old boy shows a cystic lesion with air fluid level in the right upper lobe. CT scan confirms the presence of a thin-walled cystic lesion. Rest of the lungs are clear. Correctable cause of male factor infertility. Surgical correction has a failure rate of less than 5%. An alternative to surgery is the selective catheterization and embolization of the gonadal vein. The gonadal vein is catheterized via common femoral vein puncture, and embolic material is introduced. Indications include symptomatic varicocele, recurrence of varicocele post-treatment, and varicocele with associated infertility. Complications include pain, recurrence, and reaction to iodinated contrast. Rupture of the testicular vein is a known complication, but it needs no specific treatment. Unlike surgery, embolization is not associated with postoperative hydrocele or testicular loss from inadvertent injury to testicular artery. However, there are case reports of renal loss from coil migration. Clear. There is no lymphadenopathy in the chest. Quantiferin test was negative, and there are no features of infection or signs of inflammation. What is the diagnosis? A. TBB, intrapulmonary bronchogenic cyst. C. Hydatid cyst. D. Infected bulla. E. Congenital lobar emphysema. Cassidy D. ETAL varicocele surgery or embolization, which is better? Neural Association J. 2012:6, 4266-268. 92. B. Intrapulmonary bronchogenic cyst. Bronchogenic cysts, BCS, are congenital lesions. Lesions. They are usually found in the mediastinum or pulmonary parenchyma, and, less commonly, cysts may be found in the neck, pericardium, pleura, diaphragm, or abdominal cavity. Intrapulmonary cysts are most common in the lower lobes. Intrapulmonary BCS are usually sharply defined, solitary, non-calcified, round or oval opacities confined to a single lobe. These can present as a homogeneous water density, an air-filled cyst, or with an air fluid level. Signal on MRI depends on the content, and fluid-containing lesions are low on T1, weighted, and high on T2, weighted images. However, proteinaceous content makes them high on T1, weighted imaging. The differential diagnosis of intraparenchymal BCS must include acquired cystic lesions, such as a lung abscess, a hydatid cyst, infection with nocardia, an infected bulla, congenital lobar emphysema, fungal diseases, and tuberculosis, especially when the lesions manifest as air-filled or have an air fluid level. ADEV K, ET. Emphysema. 93. A 40-year-old man presents with acute onset of 3 cranial nerve palsy. The unenhanced CT shows subarachnoid blood. Where is the aneurysm likely to be? A. Anterior communicating cerebral artery. B. Anterior cerebral artery. ETAL cystic and cavitary lung lesions in children, radiologic findings with pathologic correlation. J. Klinemag Sci, 2013, 3:60. 93. E. Posterior communicating cerebral artery. The third nerves exit the brain stem medial to the cerebral peduncles, and course forward and laterally in the interpeduncular cistern between the posterior cerebral arteries. Posterior communicating arteries, above, and superior cerebellar arteries below. The pupillary fibers are located dorsomedially and peripherally at this segment. Common pathologies involving this segment include aneurysm at or basilar tip, dolichoectatic vessels, microvascular ischemia, SAH, meningitis, neoplasms, leukemia, lymphoma, neurogenic tumors, and leptomeningiocarcinomatoses, inflammatory disease, neurosarcoidosis, Wegener's granulomatosis, demyelinating disease, transtentorial herniation, from supratentorial tumor, hemorrhage or brain swelling, and head trauma with nerve avulsion, usually at the posterior petroclinoid. Ligament where the third nerve is stretched because of downward displacement of the brain stem at the time of impact. Low CP, ETAL neuroimaging of isolated and non-isolated. Artery C, middle cerebral artery D, posterior cerebral artery E, posterior communicating cerebral artery. 94, a 7-year-old girl presents with abdominal pain, which has come on and off over the past year, and failure to thrive. An X-ray performed revealed dense metaphyseal bands in both lower limbs. The blood profile was unremarkable. What is the most likely diagnosis? A. Leukemia. B. Lead poisoning. C. Congenital rubella. D. Osteopetrosis. E. Osteopathy striata. Non-isolated third nerve palsies. BR. BRJ radial. 2012, 85, 1012 for 67. 94. B. Lead poisoning. The differential list for dense metaphyseal bands is plenty but includes normal variant in neonates, growth acceleration lines, usually in patients with chronic illnesses like diabetes, asthma, treated rickets, chronic anemia, scurvy, and lead poisoning. Recurrent abdominal pain is associated with lead poisoning. None of the other conditions, except for leukemia, is associated with abdominal pain, but the dense metaphyseal band sign is. Chapter 14. Test paper 7, answers. 415. Acknowledged only in treated leukemia rather than active leukemia. Although the blood profile is often normal, the patient may sometimes have a mild microcystic, microchromic anemia. Raber S.A. The dense metaphyseal band sign. Radiology. Striata. 95. A 63-year-old man is diagnosed with sigmoid adenocarcinoma with no metastatic spread identified on initial staging computed tomography (CT) scan. After a course of neoadjuvant chemotherapy, he is considered for tumor resection and undergoes a repeat CT scan. New hepatic lesions suspicious for metastases are identified. All of the following are criteria for resectability, except A. Less than 3 hepatic lesions. B. At least 3 segments spared from metastatic involvement. C. No visible nodal involvement. 1999, 211:773-4. 95. A. Less than 3 hepatic lesions. Liver metastases from colorectal cancer are among the most common hepatic secondary tumors. This is also the only type of metastatic deposit for which resection has shown a survival benefit. If liver metastases from colorectal cancer are to be resected, several radiological criteria must be met. There is no strict limit to the number of lesions that can be resected, but it is unlikely that more than 6 lesions will be removed. Compare this with hepatocellular carcinoma, where only a solitary lesion can be surgically explored. If at least 3 segments of the liver are spared, there are enough hepatocytes to provide liver function following surgery. Preoperative selective portal vein embolization can be used to increase the volume of the remaining liver through hypertrophy. CORRC, Callaway M, Rethi 3. D. At least 1 main portal vein branch must be spared. E. At least 1 hepatic vein must be spare. 96. A taxi driver is brought to the accident and emergency department after a high-speed road traffic accident. The fire brigade needed 2 hours to extricate him from his wrecked car. On arrival, he is hypothermic but stable, complaining of severe abdominal pain. An urgent contrast-enhanced CT scan is performed, and the radiologist on call issues a report describing features suggestive of mesenteric injury with segmental small bowel ischemia. Which finding is the most specific for a mesenteric injury with associated bowel wall ischemia? A. Generalized increased bowel wall enhancement. B. Patchy and irregular localized bowel wall enhancement. C. Localized bowel wall thickening. D. Decreased or absent bowel wall enhancement. E. Segmental bowel dilatation. 97. A. CORRC, Callaway M, Rethi 3_111, Management. 96. D. Decreased or absent bowel wall enhancement. Abnormalities in bowel wall enhancement after administration of, for contrast, are very common and important positive findings in the evaluation of abdominal CT in a trauma scenario and should always be assessed. Generalized increased enhancement is typical for bowel wall injury with vascular involvement, but without ischemia, and is thought to be caused by increased permeability of the hypoperfused wall. Localized, patchy and irregular hyperenhancement is suggestive, but not diagnostic of a full-thickness tear. Areas of decreased or absent enhancement in a segment of a bowel are indicative of bowel ischemia. Lack of enhancement is considered to be highly specific. Brody J.M., ETALCT of blunt trauma bowel and mesenteric injury, typical findings and pitfalls in diagnosis. Radiographics. 2000, 20:15-25-36. Brofman N., ETAL evaluation of evaluation of bowel and mesenteric blunt trauma with multi-detector CT, radiographics. 4-week-old neonate is being investigated for neonatal jaundice. Post-feed ultrasound of the abdomen demonstrates a normal-looking distended gallbladder and no focal hepatic abnormality. A cholecystigraphy scan, also known as hepatobiliary immunodiacetic acid (HIDA) or mebrofenin scan, demonstrates isotope in the urinary bladder at 24 hours. What is the most likely diagnosis? A. Chole cyst. B. Transient neonatal hyperbilirubinemia. C. Biliary atresia. D. Idiopathic hepatitis E. Cystic fibrosis. 98. 2006, 26:11-1931. 97. C. Biliary atresia. Failure of gallbladder emptying following a feed and failure of isotope (HIDA) excretion into the bowel is a typical finding of biliary atresia. The presence of tracer in the urinary bladder implies that there is no hepatic excretion of tracer, only urinary excretion. This only occurs with sustained systemic levels as HIDA is preferentially excreted hepatically. The gallbladder is not visualized in some cases of high biliary atresia and cystic fibrosis. Transient neonatal hyperbilirubinemia should resolve spontaneously by 2 weeks of age. Ultrasound imaging may demonstrate a triangular cord or tubular echogenic structure in the porta hepatis owing to fibrous tissue. When identified, this is pathognomonic of biliary atresia. Husman AGM. Pediatric Imaging, Case Review Series, 2nd ed. Philadelphia, PA, Mosby Elsevier, 2000. 98. Which of the following is not an angiographic sign of active bleeding? A. Contrast extravasation. B. Vessel spasm. C. Vessel cutoff. D. 2010. 98. E. Vessel dilatation. The rest are angiographic signs of active bleeding. Vessel dilatation is not. Radiology Integrated Training Initiative, RITI. 1C_016 Acute Adult GI Bleeding. D. Early venous filling. E. Vessel dilatation. 99. A 5-year-old girl presents with left-sided abdominal pain. On examination, there is a palpable mass in the left flank. Computed tomography demonstrates a well-circumscribed multiseptate cystic renal mass, which is replacing the lower pole of the left kidney. The intervening septa are thick and enhanced post-contrast, and the cysts appear to be herniating into the renal pelvis. Which of the following is the most likely diagnosis? A. Multicystic dysplastic kidney. B. Multilocular cystic nephroma. C. Nephroblastoma. D. Polycystic kidney disease. E. Mesoblastic nephroma. 100. A 54-year-old woman is having an MRI. B. Multilocular cystic nephroma. Multilocular cystic nephroma is a benign renal tumor that occurs in children and, less commonly, adult women. There is no known association with Wilms tumor. It is usually a unilateral abnormality that replaces an entire renal pole and presents as a large mass, often around 8-10 cm in diameter. Radiological appearances, while not entirely specific, can help to differentiate this lesion from other renal mass lesions. A sharply well-circumscribed, multiseptate cystic mass is typical, with a thick surrounding capsule. The cysts may appear to herniate into the renal pelvis, an appearance that is relatively specific. Unsurprisingly, these lesions are excised as a definitive radiological differentiation from malignancy is often not possible. Multilocular cystic nephroma can be differentiated from multicystic dysplastic kidney by the presence of normal functioning renal parenchyma and symmetrical renal excretion. Polycystic kidney disease involves the entire kidney, unlike multilocular cystic nephroma, which tends to be localized around a renal pole. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:957. 100. D. Parenchymal abnormalities secondary to venous occlusion are irreversible. Parenchymal lesions are better depicted and more commonly identified at MR imaging than at CT. Focal edema, without visible hemorrhage, is visible on CT images in approximately 8% of cases, and on MR images in 25% of cases. Diffuse MRI for suspected cerebral venous sinus thrombosis. With regard to parenchymal abnormalities associated with venous thrombosis, all are true, except A. Parenchymal changes are better depicted on MRI. B. DWI helps distinguish between types of cerebral edema. C. Parenchymal changes may not correlate with location of venous occlusion. Diffusion-weighted MR imaging techniques allow subclassification of parenchymal abnormalities as either primarily vasogenic edema, with increased ADC values presumably related to venous congestion, or primarily cytotoxic edema, with decreased ADC values related to cellular energy disruption. Hemorrhage may occur with both types of edema. In contrast with arterial ischemic states, many parenchymal abnormalities secondary to venous occlusion are reversible. Although parenchymal changes may occur in areas of the brain that are directly drained by the occluded venous sinus, in some patients, the parenchymal changes may not closely correlate with the location of venous occlusion. Parenchymal swelling without abnormalities in attenuation or signal intensity on images may occur in as many as 42% of patients with cerebral venous thrombosis. Sulcal effacement, diminished cistern visibility, and a reduction in ventricular size may occur. Leach JL, ETAL imaging of cerebral venous thrombosis, current techniques, spectrum of findings, and diagnostic pitfalls. Radiographics. 2006, 26, Supple 1S 1941, discussion S4. Occlusion. D. Parenchymal abnormalities secondary to venous occlusion are irreversible. E. Brain swelling with normal parenchymal signal is well recognized. 101, a 24-year-old man sustained an injury to his wrist following a fall while skiing. There is tenderness in the anatomical snuff box, particularly on ulnar deviation. Plain radiograph. Chapter 13. Test paper 7, questions. 383. Performed in casualty revels a scaphoid fracture. Which one of the following statements regarding fractures of the scaphoid bone is true? A. The distal fragment is at risk for avascular necrosis when the waist of the scaphoid is fractured. B. They usually are the result of a direct blow to the wrist. C. Fractures of the distal pole are less common than fractures of the proximal pole. D. Fractures involving the proximal pole invariably lead to avascular necrosis of the proximal fragment. E. Fractures through the waist of the scaphoid do not displace because of the strong supporting intercarpal ligaments. 100. S42-3. 101. C. Fractures of the distal pole are less common than fractures of the proximal pole. Scaphoid fractures are common injuries, but can have long-standing implications if not treated in a timely manner because of the risk of avascular necrosis and early development of osteoarthritis in cases of mal or non-union. Scaphoid fractures most commonly occur within the waist of the scaphoid, 70%, with the remaining occurring in the proximal pole, 20%, and distal pole, 10%. Due to the nature of the scaphoid blood supply, it is the proximal fracture fragment that is at risk of avascular necrosis. A fall on the outstretched hand is the most common mechanism. Fracture displacement and scapholinate ligamentous disruption with widening of scapholinate distance, Terry Thomas's sign, are common associated findings. Brady A, Raby N. (102) A 71-year-old man with biopsy-proven Gleason grade 8 adenocarcinoma and a PSA level of 5.65 Ng/ml is sent for an MRI prostate for local staging. T2W axial Mr. image shows that the dominant tumor is within the left peripheral zone extending from the apex to the base with features indicative of extracapsular extension. All the following suggest extracapsular extension, except A. Broad contact greater than 12 mm of tumor with capsule B, obliteration of rectoprostatic angle C, asymmetry of the neurovascular bundle D, nodes in the paravesical fat E, irregular capsular bulge. 103. An 8-month-old child is investigated for a 5-month history of respiratory symptoms. Chest X-ray. N. Early MRI in the management of clinical scaphoid fracture. BRJ Radiol. 2003, 76, 905 296 300. 102. D. Nodes in the paravesical fat. The strength of MRI in evaluation of prostate cancer is in the diagnosis of extracapsular and seminal vascular invasion. The criteria used for the detection of extracapsular extension of tumor on T2 weighted images include irregular capsular bulge, obliteration of rectoprostatic angle, asymmetry of the neurovascular bundle, angulation or step-off appearance of the prostate contour. Chapter 14. Test paper 7, answers. 417. Focal capsular thickening or retraction, broad, greater than 12 mm, capsular tumor contact and breach of capsule with evidence of direct tumor extension. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical. X-ray shows a right upper zone mass. MRI confirms the presence of a low T1, high T2 signal, well-defined mass displacing the trachea to the left. There is homogeneous internal signal. The lesion is separate from the spinal canal. There is no associated vertebral anomaly and no widening of the neural foramina. The patient is afebrile. What is the most likely diagnosis? Diagnosis. A. Neurofibromatosis. B. Lateral meningocele. C. Neuroenteric cyst. D. D. Lung abscess. E. Foregut duplication cyst. A textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:907. 103. E. Foregut duplication cysts. Foregut duplication cysts usually occur on the mesenteric aspect of the alimentary canal and may be associated with other gastrointestinal anomalies. The absence of any spinal involvement and the late presentation seen here rule out other differential diagnoses. Other more likely differentials would include bronchogenic cyst and pericardial cyst, and these are often very difficult to differentiate even on computed tomography, CT, and MRI. Duplication cysts occur most commonly in relation to the small bowel, in particular the ileum. The esophagus is, however, the second most common location. When identified, the muscular rim sign on ultrasound is diagnostic. This results from an alternating echogenic inner mucosal lining and a hypoechoic outer rim signal from the mucosal lining. Dannert W. Radiology Review Manual, 7th ed. 104. A 10-year-old boy has a 48-hour history of drowsiness and decreasing GCS. In the previous week, he was unwell with a chest infection. The MRI demonstrates multiple areas of hyperintensity on T2 and flare within the white matter. Contrast enhancement demonstrates open ring sign. What is the most likely diagnosis? A. Multiple sclerosis. B. Acute disseminated encephalomyelitis. C. Multiple cerebral abscesses. D. Herpes encephalitis. E. CMV encephalitis. N. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011. 104. B. B. Acute disseminated encephalomyelitis. Acute disseminated encephalomyelitis, ADEM, is a monophasic autoimmune demyelinating disease of the central nervous system that typically follows a fetal infection or vaccination. The disorder is immunologically mediated because of an autoimmune reaction to myelin. Peak incidence is in children aged 3-10 years. Typically, ADEM manifests as multifocal lesions mimicking MIS. However, clinical and radiologic criteria distinguish between ADEM and MIS. ADEM typically meets at least two of the three following criteria. A. They have clinical symptoms atypical of MS, e.g., altered consciousness, hypersomnia, seizures, cognitive impairment, hemiplegia, quadriparesis, aphasia or bilateral optic neuritis. B. They have absence of oligoclonal bands in CSF. C. They have gray matter involvement, basal ganglia, or cortical lesions. Imaging features, such as the number of T2 hyperintense lesions and the presence of gadolinium enhancement, edema, and periventricular or brainstem lesions, cannot be used to reliably differentiate between ADEM and miscorpus callosal involvement is less frequent in patients with ADEM than in those with cerebrospinal fluid findings, especially the presence or absence of oligoclonal bands, remain important in the differentiation of patients with MS from those with ADEM. The best criterion is the course of the disease, with a good outcome in 57% 81% of patients with ADEM, with no new lesions and partial or complete recovery of existing lesions on follow-up MR images. Mialinar. Encephalitis. 105. You notice an area of focal dissection at the site of angioplasty of a left common iliac lesion during your completion run. Which of the following is the next step? A. Reinflate the angioplasty balloon. B. Deploy a stent. C. Measure the pressure gradient. D. Deploy a covered stent. E. Report the finding and finish the procedure. RETAL case 173. Acute disseminated encephalomyelitis confined to the brainstem. Radiology. 2011, 260, 39, 11, 14. 105. C. Measure the pressure gradient. There will be a degree of vessel dissection in all vessels after angioplasty. If there is no limitation to flow or significant pressure gradient across the lesion, then the procedure can be regarded as being successful and no further action is necessary. The pressures can be measured by connecting the end of a catheter to a transducer via a three-way tab. The catheter is placed through stenosis and the pressures are measured on either side. The difference is the pressure gradient, and it should be less than 10 mmHg. Procedure. 106. A 32-year-old man who fell off his bike in midair during a motocross championship was brought into casualty with weakness of all four limbs and GCS of 10 out of 15. Initial CT showed. Chapter 13. Test paper 7, questions. 384. A fracture dislocation at C7/T1. An MRI was organized given that there were clinical features of acute spinal cord injury. All of the following findings are expected on the MRI, except A. Hyperintensity on T2W images. B. Swelling of the spinal cord. C. Hypointensity on T2W images suggesting hemorrhage. D. Occasional contrast enhancement. E. Atrophy of the spinal cord. 106. E. Atrophy of the spinal cord. Spinal cord injury can have devastating impacts on patients. Acute causes generally relate to traumatic events and include cord hemorrhage, contusion, and transaction. Edema, swelling and hemorrhage, AP, and intradural are often seen in the context of an acute cord injury. Chapter 14. Test paper 7, answers. 418. Occasionally, there can be increased enhancement in the hyperacute status, usually of the hematoma. Examples of causes of chronic cord myelopathy include chronic spinal stenosis, e.g., from a disc prolapse, from the sequelae of an acute cord injury, or from a demyelinating process such as multiple sclerosis. Atrophy of the spinal cord is a common finding in these scenarios. Chang FC, ETAL. 107. A 21-year-old man who presented with a growing mass in the left testis of 2-3 months duration with a palpable, non-tender, firm nodule on the surface of the left testicle. On physical examination showed a well-circumscribed hypoechoic mass with a concentric lamellar pattern of alternating hyper and hypoechoic rings on US. What is the diagnosis? A. Tunica albuginea cysts. B. Simple cyst of testis. C. Epidermoid cyst. D. Inter-Testicular ETAL traumatic spinal cord injury without CT or radiation. 107. C. Epidermoid cyst. Epidermoid cysts are also known as keratocysts. They are non-tender and usually palpable. The US appearance varies with the maturation, compactness, and quantity of keratin present within the epidermoid cyst. A target appearance, a solid mass with an echogenic rim, and a characteristic onion ring configuration with alternating layers of hyper and hypotonicity have been described. These cysts do not show blood flow at Doppler US examination. The constellation of an onion ring configuration, negative tumor marker status, and avascularity help differentiate testicular epidermoids from other germ cell tumors. The US findings of intertesticular varicocele are similar to those of extratesticular varicocele and include multiple anechoic, serpiginous, and tubular structures of varying sizes. Color flow and duplex Doppler US show a venous flow pattern with a characteristic venous spectral waveform which increases with the Valsalva maneuver. An intertesticular spermatocele is a cystic intraparenchymal lesion that is attached to the mediastinum in the area of the reedy testis. Dobra vs. ETAL benign. Intertesticular varicocele. E. Intertesticular spermocele. 108. A 2-year-old toddler is brought to the accident and emergency department by his mother with constant vomiting. During clinical examination the toddler is restless, dehydrated, and shows the signs of peritonitis. The examining doctor also notices multiple bruises of different ages, skin lacerations and scars. Visceral trauma on a background of non-accidental injury, NI, is suspected. Which of the following is not a common bowel injury associated with non-accidental trauma? A. Small bowel rupture. B. Shock bowel syndrome. C. Intramural mesenteric hematoma. D. Barr-Have syndrome. E. Duodenal. C. Intramural mesenteric hematoma. D. Barr-Have syndrome. E. 108. D. Barr-Have syndrome. Non-accidental abdominal trauma is the second leading cause of death from child abuse after head trauma. Presentation is usually delayed with abdominal pain, vomiting, keratonism, and signs of obstruction. Non-accidental visceral trauma is more common in the age group presented here than is incidental blunt abdominal injury and should always be considered as a differential diagnosis, especially if there are other associated features of NI. Visceral perforation/laceration, intramural hematoma, and shock bowel syndrome are all within the spectrum of NI. Barr-Have syndrome is a complete transmural esophageal rupture caused by forceful vomiting or impacted food bolus and more commonly affects adults. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:1505. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011. Churchill Livingstone. E. Duodenal contusions. 109. You are asked to review the chest X-ray of a postoperative patient, now in intensive treatment unit. The patient has a number of lines and tubes. Which of the following positions suggests incorrect placement? A. Endotracheal tube with the tip 2 centimeters above the carina. B. Central venous catheter with the tip in the junction of the superior vena cava / right atrium. C. Nasogastric tube with the tip below the diaphragm overlying the stomach. D. Peripherally inserted tunneled central venous catheter with the tip in the superior vena cava. E. Intra-aortic counterpulsation balloon pump in the descending aorta distal to the origin of the left subclavian artery. 110. A 2-year boy presents with a 2-week history of melena culminating in an acute. 109. A. Endotracheal tube with the tip 2 centimeters above the carina. Close evaluation of any tubes and lines should always be performed to avoid any unnecessary complications and embarrassment. The endotracheal tube should be at least 5 centimeters above the carina to allow movement of the patient's body so that it never lies within the right or left main bronchus. If it does, it can cause collapse of the non-intubated lung. Central venous catheters, including peripherally inserted catheters, should have their tip within the superior vena cava or right atrium. Intra-aortic counterpulsation balloon pumps should lie within the descending thoracic aorta with the upper aspect distal to the arch vessels to avoid obstruction of blood flow. CELA D. Chest radiograph evaluation and interpretation. AACN Advanced Critical Care. 2000. Acute episode of bright red blood per rectum. Ultrasound was unremarkable. Upper gastrointestinal endoscopy was negative. Technetium pertechnetate demonstrates increased uptake in the left upper and right lower quadrants. What is the most likely diagnosis? A. Acute appendicitis. B. Intussusception. C. Meckel's diverticulum. D. Gastronoma. E. Nonspecific inflammatory bowel disease. 110. C. Meckel's diverticulum. The findings on this technetium pertechnetate scan are typical of a Meckel's diverticulum containing ectopic gastric mucosa. The uptake in the left upper quadrant should not mislead the radiologist, as it is the result of normal tracer uptake in the stomach mucosa. Secretions from ectopic gastric tissue in a Meckel's diverticulum can cause ulceration of the diverticulum or adjacent small bowel and can lead to bleeding, which, if profuse, can simulate an upper gastrointestinal bleed. Meckel's diverticulum may simulate acute appendicitis on clinical examination. However, a pertechnetate scan is only performed if a Meckel's diverticulum is suspected clinically. A gastronoma is usually located in the pancreatic islet cells, not the right iliac fossa. Dannert W. Radiology Review Manual, 7th ed. Dannert W. Radiology Review. 111. The following are appropriate Mr. Spectroscopy findings, except A. Canavan disease characteristically demonstrates reduced Na. B. Decreased Na and higher CHO/CR ratio signifies high-grade malignancy. Chapter 13. Test paper 7, questions. 385. C. Lipid peaks suggest infracted brain. D. Absent choline can distinguish toxoplasmosis from lymphoma. E. PML may demonstrate elevated muinositol. Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams & Wilkins, 2011. 111. A. Canavan disease characteristically demonstrates reduced Na. Mr. Spectroscopy, MRS, allows tissue to be interrogated for the presence and concentration of various metabolites. MRS can help increase our ability to grade gliomas. As the grade increases, Na and creatine decrease and choline, lipids and lactate increase. In recurrent tumor, choline will be elevated, whereas in radiation change, Na, choline and creatine will all be low. With regard to ischemic and infraction, lactate will increase as the brain switches to anaerobic metabolism. When infarction takes place, lipids are released and peaks appear. With regard to HIV, choline is low or absent in toxoplasmosis, whereas it is elevated in lymphoma, helping to distinguish the two. PML may demonstrate elevated myoinositol. Canavan disease characteristically demonstrates elevated Na. Allokili RN, ETAL Advanced MR Imaging Techniques in the Diagnosis of Intraxial Brain Tumors in Adults. Radiographics. 2006, 26, Supple 1 S17389. Bradley W.G., Bitter G.M. Myoinositol. 112, a 44-year-old man with chronic back pain underwent a spinal X-ray, which showed extensive marginal osteophytes with flowing ossification along the anterior aspect of more than 4 vertebrae with no significant facet joint arthropathy. Intervening disc spaces were maintained with no loss of disc height. In the extremities, generally symmetric enthesophytes are seen most commonly in the A, metacarpals, metatarsals and terminal tufts. B, calcaneus, patella, and olecranon. C, lesser trochanter and acetabulum. D, medial and lateral epicondyle of humerus. E, glenohumeral joint and greater GM, Advanced Mr. Imaging Techniques. London, Informa Healthcare, 1997. Bradley W.G., Bitter G.M., Advanced Mr. Imaging Techniques. London, Informa Healthcare, 1997. 112, B, calcaneus, patella, and olecranon. The description is characteristic of diffuse idiopathic skeletal hyperostosis, or commonly known as DISH. The predominant finding is the calcification/ossification of the ligament and tendon enthesis, most often in the spine. Within the thoracic spine, the ossification tends to occur on the right anterolateral aspect with postulated theories that the pulsations from the adjacent left-sided thoracic aorta inhibits the hypertrophic ossification. The most common diagnostic criteria employed is the involvement of at least 4 contiguous vertebrae, flowing ossification from calcification of the anterior longitudinal ligament, and the absence of sacroiliac inflammatory change and apophyseal joint degeneration. Recent changes have proposed reducing the contiguous vertebral segment involvement to 3 rather than 4. Extraspinal manifestations are again of calcification of the enthesis and hypertrophic bone changes, with the most common sites involving the olecranon, patella, and calcaneum. Camisa M, ETAL diffuse idiopathic. Tuberosity. 113. A 69-year-old man with a history of non-muscle invasive urothelial carcinoma of bladder treated with transurethral resection and intravesical BCG therapy presented with a firm palpable nodule on PR examination. MRI showed a low T2 signal lesion with high signal on DWMR, low signal on ADC map, and non-enhancement on subtracted contrast enhanced images in the peripheral gland. Gland at 4 o'clock. The findings were stable on an MR repeated at 9 months. A. Prostatic carcinoma. B. Post-inflammatory scar. C. Post-biopsy hemorrhage. D. Granulomatous prostatitis. E. Post-radiotherapy change. 114. A4. Resnick. D. ETAL diffuse idiopathic skeletal hyperostosis. 113. D. Granulomatous prostatitis. Granulomatous prostatitis is an inflammatory entity that often presents with a firm nodule on digital rectal examination and elevated prostate-specific antigen, thus clinically mimicking prostate cancer. Possible causes include previous intravesical BCG therapy, TB prostatitis, and previous interventions such as TURP, although most cases are idiopathic. On MRI, granulomatous prostatitis may appear as a discrete mass with markedly abnormal T2 signal, DWI, and ADC map. Furthermore, there may be associated infiltration of the periprostatic fat by inflammation, thus. Chapter 14. Test paper 7, answers. 420. Mimicking extraprostatic tumor extension. Currently, histopathologic analysis is regarded as the only means of definitively establishing the diagnosis and thereby excluding the presence of tumor. However, a suggestive history, such as prior BCG therapy, may be useful in prompting consideration of the diagnosis. In addition, the presence on MRI of large areas of non-enhancement, indicative of necrosis within the lesion corresponding with caseous abscess on pathologic evaluation, may suggest the diagnosis. A short-term follow-up MRI may be obtained after antimicrobial treatment to assess for therapeutic response. Rosenkranz, Tuneja SS, radiologist, be aware, 10 pitfalls that confound the interpretation of multiparametric prostate MRI. AJR-AMJ 14-year-old boy who accidentally fell from a second-floor window underwent an urgent computed tomography scan. It revealed diffuse small bowel wall thickening with increased enhancement of bowel wall following intravenous contrast. A flattened inferior vena cava and retroperitoneal edema were also noted in the radiological report. What is the most likely diagnosis? A. Small bowel wall contusion. B. Rentgenol. 2014, 202:10920. 114. E. Shocked bowel syndrome. Isolated, localized small bowel wall thickening is nonspecific, but highly suggestive of underlying bowel wall or mesenteric injury in the trauma patient. In all of the above conditions, apart from shocked bowel syndrome, this finding may be present. Diffuse bowel wall thickening is atypical for bowel wall injury. Following trauma, in the presence of increased bowel wall enhancement. A flattened inferior vena cava, hyperenhancement of adrenal glands and pancreatic and / or retroperitoneal edema, a shocked bowel syndrome, hypoperfusion complex, is the most likely explanation. This must not be omitted in the differential diagnosis as treatment of hypoperfusion complex is conservative, and there is B. Isolated mesenteric hematoma. C. Incomplete jejunal wall tear. D. Complete ileal wall tear. E. Shocked bowel syndrome. 115. A 65-year-old man with recurrent bouts of acute red-hot swollen first MTPJ of the right foot showed classic features of gout on plain radiograph. Which one of the following statements regarding the radiographic appearance of gouty tophi is false? A. They can contain some degree of calcification. B. They are asymmetric soft tissue masses. C. They may form in bursae. D. Tophaceous deposits in tendons may result in tendon rupture. E. They classically are intra-articular in location. There is no need for diagnostic laparotomy. Adam A. E.T.A.L. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:1504. 115. E. They classically are intra-articular in location. Gout is the clinical condition of symptomatic arthritis due to the deposition of monosodium urate crystals within or around the joints due to excess serum urate levels. There is often accompanying renal disease with formation of uric acid urinary calculi. Tophaceous gout presents with an eccentric, asymmetric soft tissue mass, ES, around the joint, S, and it is this that gives rise to the typical juxta-articular erosions. Intra-articular erosions can also occur, though this is less common. Large overhanging edges of bone often develop, separating the tophi from the erosions. Logger J. ETAL nonseptic monoarthritis, imaging features with clinical and histopathologic correlation. Radiographics. 2020, S26378. Location. 116. A 9-month-old boy with recurrent urinary tract infections and renal pelvis dilatation is referred for a micturating cystourethrogram, MCUG. The patient is currently taking a prophylactic dose of trimethoprim. With regard to performing an MCUG in this patient, which of the following instructions would you give his mother? A. The patient should continue on his current regime of antibiotics until his physicians advise him to stop. Chapter 13. Test paper 7, questions. 386. B. The patient should stop taking their antibiotics the day before the procedure and restart the medication the day after the procedure. C. The patient should take a course of treatment dose trimethoprim, starting on the day of the procedure for 3 subsequent days. D. The patient should take a 5-day course of treatment dose trimethoprim, starting on the day before the procedure. E. The patient should stop their antibiotics the day before the procedure and take a 3-day course of treatment dose gentamicin. 117. Which of the following is incorrect? C. The patient should take a course of treatment dose trimethoprim, starting on the day of the procedure for 3 subsequent days. Ensure that the baby undergoing MCUG receives 4 mg/kg of trimethoprim on the day of the MCUG, and for 3 subsequent days to prevent complication of infection. If a child is on prophylactic 2 mg/kg dose of trimethoprim, full dose is required as described above to cover the MCUG. Rennie J.M., Kendall G. A Manual of Neonatal Intensive Care, 5th. Rennie J.M., Kendall G. Incorrect. Supratentorial tumor features. A. Astrocytoma solid with a necrotic center or cystic with a mural nodule. Associated with NF1B, craniopharyngioma cystic or solid tumor with a partially calcified suprasellar mass presenting with endocrine abnormalities. C. Peanut heterogeneous hemispheric mass. Necrosis, hemorrhage and enhancement are common. D. Choroid plexus papilloma poorly circumscribed and poorly enhancing tumors. E. Ganglioglioma well circumscribed peripheral tumor that often presents with seizures. Rennie J.M., Kendall G. A Manual of Neonatal. Predominant imaging patterns of astrocytoma. Astrocytoma are mass with enhancing or non-enhancing cyst, and an intensely enhancing neural nodule, necrotic mass with a central non-enhancing zone, or predominantly solid mass. They are associated with NF1. Craniopharyngiomas are relatively benign neoplasms arising in the cellar/supracellar region, often presenting with endocrine abnormalities. Pediatric craniopharyngiomas typically appear multicystic. The solid portions enhancing heterogeneously with characteristic calcifications in pediatric craniopharyngiomas may not be discernible without SWI. Occasionally, they are predominantly solid, typically without calcification. PNETs arise from primitive, undifferentiated brain cells. They are typically heterogeneous and are usually ISO to hyperdense on CT, with calcifications in 70%. On MRI, they may appear. Chapter 14. Test paper 7, answers. 421. ISO to hyperintense to gray matter on FLAIR and T2 weighted images. The solid component usually has avid heterogeneous enhancement with minimal edema. Necrosis and hemorrhage are common and are seen as restriction on DWI. On MR images, choroid plexus papillomas appear as iso-intense to hypointense interventricular masses compared with normal brain parenchyma. Flow voids consistent with flowing blood are common. CT show intense enhancement. Hydrocephalus is very common. Gangliobliomas develop in the temporal lobe and are commonly associated with refractory seizures. Seizures partial complex type. Calcification is seen in 30%. Peripherally located gangliobliomas may cause scalloped pressure erosion of the calvaria. At MRI, a well-defined cystic mass with a solid neural nodule is typically seen. However, a solid mass with non-specific low to intermediate signal intensity on T1 weighted images and high signal on T2 weighted images is also not uncommon. Enhancement is variable, ranging from non-enhancing to ring-like to intense homogeneity. There is usually little associated mass effect or edema. Borgia M.J. E. (118) A chest X-ray is performed on a patient 1 week following a left pneumonectomy for bronchogenic carcinoma. Which of the following would you not normally expect to see? A. Loss of volume of the left hemithorax. B. Mediastinal shift to the left. C. Tracheal shift to the right. D. An enlarging left-sided hydrothorax. E. Shin J.H. ETAL neuronal tumors of the central nervous system, radiologic findings and tracheal shift to the contralateral side from the pneumonectomy is an abnormal finding, and along with depression of the ipsilateral hemidiaphragm may represent a bronchopleural fistula, empyema, or hemorrhage. Hydrothorax. E. Elevation of the left hemidiaphragm. 119. A 74-year-old man with painless hematuria and weight loss with irregular thickening of the bladder wall on US underwent an MRI for staging. MRI revealed focal plaque-like thickening in the bladder wall and areas of thin calcification on plain film. All of the following are recognized findings in squamous cell carcinoma of the bladder, except A. Single enhancing bladder mass. B. Papillary tumor with pure interluminal growth. C. Sessile enhancing tumor mass. D. Calcification related to tumor. E. Mass in a diverticula. 119. B. Papillary tumor with pure interluminal growth. Squamous cell carcinoma accounts for 5% of bladder neoplasms. However, in parts of the world where schistosomiasis, bilharzisis, is endemic, it is a major health problem, accounting for over 50% of bladder cancers. Risk factors in non-bilharzial regions include chronic irritation from indwelling catheters, bladder calculi, or chronic infection. All of these risk factors may be present in paraplegic patients, putting them at increased risk. Cyclophosphamide, smoking, and intravesical BCG has also been implicated in the pathogenesis of squamous carcinoma of the bladder. The imaging findings in squamous carcinoma are nonspecific. Tumors may appear as a single enhancing bladder mass or as diffuse or focal wall thickening. Intradiverticular squamous tumors are soft tissue masses, sometimes with surface calcification. In contrast to urothelial carcinoma, squamous carcinoma is sessile rather than papillary, and pure interluminal growth is not seen. Bladder wall thickening and calcification from chronic inflammation or infection with bilharzia may coexist and complicate the diagnosis. 120. B. Mesenteric fat infiltration significant. 120. A restrained driver of a car involved in a high-speed road traffic accident is brought to the emergency department. He is hypovolemic, tachycardic, and has a very tender abdomen. After stabilization, an urgent intravenous contrast-enhanced CT scan is performed which show features of significant mesenteric injury, and the patient is immediately taken to theater. Which CT sign is not specific for significant mesenteric injury? A. Mesenteric contrast extravasation. B. Mesenteric fat infiltration. C. Mesenteric vascular beating. D. Termination of mesenteric vessels. E. Bowel ischemia. Mesenteric injury requires urgent vascular surgical treatment and, if missed, can lead to life-threatening bowel ischemia. The most specific CT feature of significant mesenteric injury is mesenteric contrast extravasation, which is almost 100% sensitive. Other highly specific features are vascular beating, irregularity of mesenteric vessels, and termination of mesenteric vessels, which, when seen, are an indication for vascular surgery. Lack of bowel wall enhancement is highly suggestive of segmental bowel ischemia secondary to significant vascular injury. Mesenteric fat infiltration is a common but very nonspecific feature of abdominal trauma. It may be present in bowel wall laceration, contusion, or incomplete bowel wall tear, as well as in significant bowel and mesenteric injuries. Brofman N. ETAL evaluation of bowel and mesenteric blunt trauma with multi-detector CT, radiographics. 2006, 26:11 1931.